India, the land of culture, diversity and hospitality, is steadily growing in stature as a leading hub for care.
A unit committed to bring children and women's health needs at every age, every stage. Also, in times of emergencies, Medicava Hospitals is well equipped with life-supporting systems and experienced doctors to provide utmost care in that time of golden hour. Safety. In times of pandemic or any health crisis, Medicava Hospitals provides you with right weapons to win the health battles. With home care services, online consultations, stringent COVID protocols and exceptional treatment, Medicava Hospitals has always provided the right care at the right time.
We are organizing a symposium on LVAD, which comprehensively covers patient selection, pre, intra and post-op management, and also troubleshooting of these devices in patients. I would like to invite all of you to this path-breaking learning so that we can serve all our heart failure patients.
Now we are using more and more mechanical circulatory support device or ventilator assist device nowadays, and we should know everything about LVAD and its indications, how to do it and how to manage patients with LVAD.
The newer generation left ventricular assist devices are on par with transplant and are giving better results sometimes. Hence, we have organized a focused
India, the land of culture, diversity, and hospitality, is steadily growing in stature as a leading hub for healthcare in the world. With availability of world's finest medical talent, resources, and infrastructure, India's vision for healthcare is far-reaching, futuristic, and empowering. Playing a key part in this vision is Medicover, the leading multi-speciality hospital chain in India. Medicover is one of the largest healthcare providers in Europe with a significant presence in India. The group provides a broad spectrum of healthcare services via an extensive network of clinics, hospitals, specialty care facilities, fertility centers, and diagnostic labs.
Basic idea and philosophy of Medicover is in charity, and majority of the share in fact is pledged to the charity. And not only that, the same thing is extended in the healthcare delivery, in this. So if you see, compare the cost of treatment
many of these devices in patients. I would like to invite all of you to this path-breaking learning so that we can serve all our heart failure patients.
Now we are using more and more mechanical circulatory support device or ventilator assist device nowadays, and we should know everything about LVAD and its indications, how to do it and how to manage patients with LVAD.
The newer generation left ventricular assist devices are on par with transplant and are giving better results sometimes. Hence, we have organized a focused session on LVAD this 27th November at Trident Hotel between 9 and 2 p.m. Please join us there.
India, the land of culture, diversity, and hospitality, is steadily growing in stature as a leading hub for healthcare in the world. With availability of world's finest medical talent, resources, and infrastructure, India's vision for healthcare is far-reaching, futuristic, and empowering. Playing a key part in this vision is Medicover, the leading multi-speciality hospital chain in India. Medicover is one of the largest healthcare providers in Europe with a significant presence in India. The group provides a broad spectrum of healthcare services via an extensive network of clinics, hospitals, specialty care facilities, fertility centers, and diagnostic labs.
Basic idea and philosophy of Medicover is in charity, and majority of the share, in fact, is pledged to the charity. And not only that, the same thing is extended in the healthcare delivery, in this. So if you see, compare the cost of treatment versus the West versus this country, it's almost 10 times more for the same healthcare. But with the same quality, we try to provide, the best of healthcare at the most affordable prices. So that is what Medicover is trying to do in this country. And with this vision, I think it is going to
Very good morning, all. May I request everyone to please settle down? Once again, a very good morning. We are gathered here today for symposium on LVAD focused update. To give a brief about LVAD, LVAD is a mechanical device aiding the ailing heart to function as normal as possible for the heart to pump blood to the need of to the need of the body. To say in simple terms, LVAD is an advanced option to treat heart failure. And to give a brief of modalities under heart failure treatment, which can be differentiated into basic and advanced. Clinical practice guideline directed medical therapy, ICD, CRT, intra-aortic balloon pump, ECMO, Impella. These can be classified as basic, and the advanced options consist of LVAD and heart transplant. And to kick off the session, I'd invite Dr. Satish, Group Medical Director, Medical Hospitals, Dr. Rakesh, CMO, Medical Hospitals India, to come onto the dais, please. May I invite the heart failure team, Medicover Hospitals, Madhapur, Dr. Avinash, CTVS Begumpet, Dr. Balaji sir, Dr. Brujraman, Dr. Pramod sir, and Dr. Gansham sir. May I invite the guests to please light the lamp and start the session.
Sometimes you should take also. Before we start the inauguration lamp lighting, we just would like to tell you about Medicover, especially for the cardiology. I think we do at the group level around 2,500 cath procedures a month and around 600 to 650 plasties we do, and almost 20 to 25% are complex procedures across the group we do. And we have almost more than 65 doctors, expert cardiologists work in the group. So it is one of the biggest cardiology group in India, there at the Medicover hospitals. So it's a proud moment for all of us to start these symposiums like disease-specific, treatment-specific symposiums. We would like to start and we would try and educate more experts actually. I think recently we had done on heart failure. And today we are just going to start, we have the training symposium on one and LVAD. So that we want to do more trainings on disease and treatment specific. Hope these sessions will definitely help the budding cardiologists, DMD students, whatever, and practicing cardiologists and smaller hospitals so that they will learn more things. Thank you very much and welcome to the inauguration session. We have 5, 2 to 3 debate. All CTs one hand, sir. All ICs one hand.
You need one support from
Last. One photo.
happy with that. We'll start the session. And as I've told you, left ventricular assist device is an advanced option for the treatment of heart failure. The prevalence of heart failure in India is possibly on the rise as India remains doubly burdened by the rise in the risk factors of traditional cardiovascular disease and by the persistence of pre-transitional diseases such as rheumatic heart disease, endomyocardial fibrosis, tuberculous pericardial disease, and anemia. Prevention of heart failure, a target that can be overlooked in clinical practice, offers several effective opportunities for clinicians and for patients. Reliable estimates of heart failure are lacking in India because of the absence of surveillance program to track incidence, prevalence, outcomes, and key causes of heart failure. Nevertheless, the incidence and prevalence rates of heart failure are rising due to population, epidemiological, and health transitions. Based on disease-specific estimates of prevalence and incidence rates of heart failure, we can conservatively estimate the prevalence of heart failure in India due to coronary heart disease, hypertension, obesity, diabetes, and rheumatic heart disease to range from 1.3 to 4.6 million with an annual incidence of 491,600 to 1.8 million. The population of India is aging due to recent successes against communicable diseases such that the number of people above 60 years old will increase from 62 million in 1996 to 113 million to 2016. Heart failure is predominantly a disease of the elderly. As a lifetime risk for heart failure increases with age, so the burden of heart failure is likely to increase with the aging population. Since patients have uneven and limited access to healthcare in India, the healthcare infrastructure itself may play a role in the rising burden of heart failure. India's elderly population, aging 60 and above, is projected to touch 194 million in 2031 from 138 million in 2021, a 41% increase over a decade, according to the National Statistical Office. And with that, without much ado, I welcome our keynote speaker, Dr. Krishna Prasad sir, onto the dais.
Good morning, everyone. I'll not take much time. This is just an introductory one. Basically, I welcome you all to this focused symposium on LVAD. LVAD, or ventricular assist device, usually gets thrown in between a lot of other things in heart failure management, transplants, and everything. So we thought it might be a better idea to have just a focused session on LVAD so that we can know in and out about ventricular assist devices, how we can adapt it. And I think Medicover Hospitals is poised at the right point with 25 hospitals across 3 states and an ever-expanding group. We can set a right example of a hub and spoke model or identifying patients with heart failure and how we can give them a better care. So today's session is entirely focused on ventricular assist devices and how they should be managed, who are the patients, and I'm sure at the end of this session, we'll all be more enlightened about ventricular assist devices. I'm very pleased to have Dr. Mridula Reddy, MD DM, heart failure and transplant cardiologist, co-medical director, heart failure and MCS program from Miami Transplant Institute, Jackson Memorial Hospital. Thank you, Ma. And it's a privilege to have you here. And we have equally privileged moderators, Dr. Sandeep Attavar and Dr. Amaresh, and we have our senior colleague, Dr. Avinash Dal here. We will take inputs from them as well. And hopefully this would turn out to be a very educative session. So without much of a delay, let's start the sessions. First, I'd like to invite Dr. Nitin to talk about case selection and pre-operative evaluation. The moderators for this would be Dr. Avinash, Dr. Ghansham, Dr. Pramod, And when Dr. Amaresh comes, he will join us. Thank you.
Thank you, Dr. KP. Well, one of the most fundamental aspects of clinical medicine has always been, whether it's the most basic to the most advanced intervention, has been the appropriate case selection. Well, no two patients are the same, and the same disease in two patients may not manifest with similar problems and management strategies. And when we're talking about an extremely advanced intervention such as the LVAD, we need to be very sure about what kind of patients we choose. And to take us through this, we have with us Dr. Nitin. Over to Nitin.
Exactly right. Patient selection is the key. And when the outcomes are good and over a period of time when the experience is gained, then subsequently, obviously, the risk-taking level goes up. So if the early cases end up being complicated, or if they end up having prolonged ICU course, either because of the RV failure or some bleeding complications, that's going to lead to kind of confidence generation in the team, not in the core physician team, but the peripheral team, like your nurses, your referring physicians can go down. So it's very important to select the right patients so that people can understand, including your referring physicians, nursing staff, ancillary staff, that this is a true therapy. If they see a lot of failure early on, the belief in the therapy itself might go down. So it's crucial to select right patient population, especially for the beginning programs, to generate that confidence in your team and in patients and in the communities. So I couldn't have said it better. You started it on a right note.
Yeah. Good morning, all. See, last 2 decades, no field in the cardiology has seen such an explosive growth like mechanical circulatory assist devices, especially LVAD. So, in spite of this much success, so there are some shortbacks are there. So we can't advise these devices for everybody, and we have to be very choosy. We have to identify these cases at right time to give a very good result. So with these notes, just to go through the presentation of how to select a case for LVAD. So first of all, we need to define advanced stages of heart failure. So there are different definitions as per ACC-AHA. It's defined as refractory heart failure, that is stage D, and then NIHA classifies as class 3 or class 3B and class 4. But this is very vague, so because the putting all the advanced heart failure into 1 or 2 classes is too short, and then it doesn't serve the purpose to whether to advise them MCS or not. So with this, there are multiple definitions, definitive criteria were given by different cardiology associations like ESC and AHA and then Heart Failure Society of America. So the center point is they should be having severe symptoms and then functional limitations, and then even after giving a guideline-directed medical therapy, there should not be significant disability, and then there should not be much improvement. So then this is the accepted criteria by ESC, that is Heart Failure Association. So it has 3 components. One thing is patient symptoms, functional capacity, and then echocardiography. So the patient should have a severe and persistent symptoms of heart failure, either class 3B NIHA or class 4, in spite of taking optimal medical management, and then LVEF of capacity. So you can do 6 minutes walk distance of less than 300 meters, and then if you do exercise pulmonary test, then maximum oxygen consumption of less than 12 ml per kg per minute, or less than 50% of the predicted value of that patient. So this is the criteria to be followed. So then the importance of guideline-directed medical therapy. So all the foundational therapies which consist of RAS inhibitors, beta blockers, MRA, and then SGLT inhibitors. If you give correctly, so they have significant impact on the patient's survival as well as quality of life. So the relative risk reduction can be reduced by almost 80%, and then it can add almost 6 to 8 years of life to the patients. So then always we have to try with optimal medical management, and then it has to be given as per the recommendations. And then still if the patient is not improving, so the many patients, if they see the natural history of the heart failure, they will progress. So with because of the remodeling of the LV, and then they will end up, at least 10% of the patients of heart failure, they will end up in advanced heart failure, so where they won't respond to the routine medical management. And then at this point of time you have to identify at the correct time, so that they won't fall into very late stages and they will end up in pump failure where no other treatment will work, and then they have other end organ dysfunctions. And then if we can't we can't offer this procedure for less sick patient, so because they have some disadvantages. So especially with the LVADs, they have to be there is external drive line related to infection, or they require power supply, and then even for transplant also they require immunosuppression and other related things. So then we have to pick up at ideal time interval, and then if you won't treat properly, so advanced stage of heart failure is equal to the malignancy. So with a 1 year mortality of around almost 75% with a class 4 heart failure. So the options for advanced heart failure are, the gold standard is heart transplant, but with limitations of donor availability as well as, so then comorbidities, they may prevent from the patient from going to transplant. And then continuous or intermittent inotropic support, but it's almost futile for many patients. And then the next option, the most important one, is VAD. And then if you see the growth of the VAD versus heart transplant, for the heart transplant for the last 30 years, almost the numbers are same. But left ventricular assist device usage, it's increasing drastically over the last few years, and especially latest data of Momentum 3, 2018, it has picked up. So previously it was more often used as a bridge therapy. So but now, last 2019, you can see 90% are destination therapy, and only around 10 to 20% are used as a bridge to transplant or bridge to other things. So this is the data. So this is because of the advancement in technology of the LVAD, and then surgical improvement as well as the patient care. But it comes with some pros and cons. So advantage with LVAD, so you can stabilize the patient, it causes reverse remodeling of the LV, and you can preserve all other end organs, and then it improves survival and then as well as quality of life. But it has some negative things like surgical risk and then pump related issues. That is, one thing is drive line, external drive line, second thing is requirement of pump, so more power supply. And especially in Indian setting, it adds to the caregiver burden also. Many of the patients, they don't know how to operate, and then they require caregiver support. And then also in Indian setting, it adds to financial burden. So this is the reason why we need to identify a correct point, and then there is a golden window for referral. So so these are the high risk clinical triggers. So when you see these things, you have to refer to advanced heart failure clinic, so that they will follow up and they will identify, and then they will do workup whether the patient is a candidate for advanced therapies, either like LVAD. So first thing is requirement of IV inotropic support, and then persistently severe symptoms, that is NIHA class 3B or class 4, or persistent elevations of natriuretic peptides. Ideally, any patient got admitted for a heart failure. So before discharge, at least 30% reduction in the NT-proBNP or BNP level should be there. And then if she is not responding to medical therapy alone, then probably the patient requires VAD support. And then other end organ dysfunctions, creatinine of more than 1.8 or BN of more than 43. So these patients they should be identified early. So because at this stage, if you improve the LV function, then again there is the reversible component of hepatic and renal dysfunction. But if it's too late, and then they'll end up in irreversible damage to the other end organs. And then ejection fraction of equal to or less than 35%, and then multiple defib shocks, and then multiple hospitalizations, that is more than one per year, and then persistent edema, and then despite using diuretics or increasing the dosage of diuretics, low blood pressure and high heart rate, that is low cardiac output symptoms, and patient who was tolerating GDMT prior, but now he is unable to tolerate the routine GDMT, means that is also one of the clinical trigger. So we should think about other advanced therapies. And the patient is already on CRT, which was previously patient was responding, but now CRT is non-responding, and then significant impairment of quality of life. These things, if you are there, that is the mnemonic, that is I need help. So then these people should be considered for advanced therapies, especially LVAD. So as per latest guidelines, that is Momentum 3 trial, the indications for LVAD are significant symptoms despite of optimal medical therapy. The patient is on medications at least for 60 days, and then in spite of that, patient is having significant symptoms on 45 days of the last 60 days, and then LVEF of less than 25%, and then peak oxygen consumption less than 14 ml per kg per minute, are requiring continuous IV support. Or patient is on short-term MCS like intra-aortic balloon pump for more than 7 days, and then requiring inotropic support for more than 14 days. So these are the indications to consider VAD support. So but this NIHA classification, it's too short, and then before considering for LVAD, this will not help in identifying the patient early. So the NIHA class includes the patients who are in cardiogenic shock, as well as the patient is symptom limited but is ambulatory, staying at home. So the both are fitting into the same NIHA class 3B or NIHA class 4. So, but there are a lot of population, there's a lot of variation in the symptomatology and presentation. So that doesn't reflect exact advanced heart failure status. So that is the reason why that is FDA and CMS and then Heart Failure Association combinedly, jointly formed the INTERMAC registry, that is the Interagency Registry for MACs, that is Mechanical Assisted Circulatory Support Systems. So this has given the patient-specific clinical profiles. These patients of advanced heart failure are divided into 7 clinical profiles. The one is sickest, and 7 is the most benign or less symptomatic. The class 1, clinical profile 1 is in cardiogenic shock, that is crash and burn state. And then clinical profile 2 is patient is on inotropes, but still he is sliding on inotropes. The clinical profile 3 is patient is stable on inotropes, but unable to wean off inotropes, or at least patient is on other short-term MCS like IABP or Impella and other devices. With that he is stable, but we are unable to wean off the supports. And then the 1, 2, 3 are inotrope dependent. And then class 4 to 7 are, they are not inotrope dependent, they are ambulatory. Class 4 is patient is requiring multiple hospitalizations for either low flow states or congestion or because of arrhythmias. They are called frequent flyers. And then class 5 is the patient is ambulatory, but he is exercise intolerant or housebound state. And then clinical profile 6 is exertion limited or walking wounded. And profile 7 is advanced NIHA class 3. So at present, this clinical profile 7 there is no recommendation for the VAD, but 1 to 6 it's recommended. That we'll discuss in the next topic. So you see, the class 1 is the most sickest patient, and then usually it's too late. So already the LVAD implantation, sometimes it may be futile, but usually it worth trying, but usually it has to be implanted within hours. Patient won't give time, but usually we'll give short-term mechanical circulatory support system for some time, and then we'll go for long-term LVAD as a destination therapy. And Intermax 2 and 3 profile are very good patient, ideal patients. They are very much stable, they are preserved, and then they are given time, days to weeks, and then you can plan perfectly, and then you can do implant with a very, very good result. And then Intermax 4, they are ambulatory, but they are having frequent hospital admissions. So they are also ideal patients. And then class 5 to 7, that is too early, but 5 to 6, there are some trials, and then 7 is not required. So you can see, even clinical outcomes based on Intermax profile, the patients, class 1, their survival rate was less, as well as total length of hospital stay was almost 44 days. The early patients like Intermax 4, the actual survival is better, and then total hospital stay was only 17 days. So if you pick up early, both survival as well as the hospital stay and other things, they'll improve. So this is the present recommendations. Inotrope dependent. So 80% of the LVAD implantations across the globe, it's in these patients, and there is a lot of data, and this is definitely indicated. And then ambulatory patients, so usually they contribute to 20% of the LVAD implantations, and then there is limited adoption. But because of the recent advances, especially there is smaller devices with HeartMate 3, so in future these people will also be eligible for, and then these people will be accepted for LVAD implantation. So some other, we need to know about exclusion criteria also. So if the patient is having, first of all, we need to rule out all the reversible causes of the heart failure with angiography, and then even MRI and those things, and then before suggesting a LVAD. And then patient requires lifelong anticoagulation as well as antiplatelet therapy. So then if we need to rule out any coagulopathies, and then any uncontrolled infection, it's also contraindication, and irreversible hepatic and renal dysfunction. So before that, before ruling out any case because of renal dysfunction and hepatic dysfunction, we have to try to optimize with the medicines as well as short-term MCS, so that many times there may be reversible component, then only we can exclude. And then if there is any lung disease which impacts overall survival, that is a contraindication. And then patient has to be intact psychologically as well as neurologically. So if there is any neurological defect, and then patient is not psychologically intact, so then because the patient has to deal life with LVAD, so that is also contraindication. And then any other disease which affects his life expectancy. And then there are certain things even regarding cardiac things also, like peripheral vascular disease and valvular heart disease and structural heart disease, and then this we'll discuss. See, then how to evaluate, once you identify the patient as probably he's a candidate for LVAD, he has indications, but then what are things to look before assessing assessing the risk, and then how to proceed for LVAD. First we have to exclude reversible causes, and then we have to assess this cardiac, other cardiac diseases like valvular heart disease, structural heart disease. And then history of any previous cardiac surgery is also important, especially if it is a CABG. So then we need to see where the grafts were placed, and then even assess the ascending aorta, so where you are going to give a graft. So we have to do thorough echo. So echo we need to see for chamber dimensions, especially LV size. Usually if it is more than 6.2, so then it is a good. So because if LV cavity is small, so then they may cause low flow events. And then we have to see RV and LV systolic function, The main glitch is assessing RV function on the echo. So there are no parameter on the echo that can accurately assess the RV function because of its geometry, but we have to assess by either RV fractional shortening and then RV strain and then TAPSE. So TAPSE usually, if it is more than 16, it is the ideal candidate, and if it is less than 8, it's a very high risk of developing RV dysfunction after the LVAD. And then we need to assess all the valvular lesions. And then we have to see for any shunts. So any shunt before surgery that may lead to right to left shunt after procedure. And then you have to see carefully about clot. So main thing regarding selection of the patient is assessing the RV function. So because once you do LV assess device, so then the venous return will increase, then RV is exposed to the excess venous return. So if there is an unmasked RV dysfunction, because previously the low cardiac output, so RV dysfunction may be masked. Once it is exposed to the normal cardiac output, that is increased venous return, so then it may be unmasked. And that is the one thing. Even the second thing is, once you put a LVAD, so then IVS geometry will change and it acts as if it is a part of LV. So then because of that, then also it causes RV dysfunction. So because of these two reasons, we need to assess the RV function accurately, and then we need to assess the chance of developing RV dysfunction even before doing a LVAD. So usually in data shows that the chance of RV dysfunction after LVAD ranges from 5 to 40%. This is the one, and even sometimes late RV dysfunction is also possible. So it can be assessed. No parameter gives accurate information about post-LVAD RV dysfunction. But these are the parameters we need to see. One thing is clinical characteristics of the patient, usually female gender, and use of any patient requiring inotropes or IABP before the procedure of LVAD. And then if the patient is having already other end organ dysfunction like hepatic and renal dysfunction, they are likely to develop RV dysfunction more. And then echocardiographic features, RV to LV diameter ratio of more than 0.75, and then RV free wall strain by speckled tract is less than -9. These are few factors so which predict the RV dysfunction. And but before LVAD, we need to do right heart catheterization, and then we need to see further some parameters which will guide you regarding the RV function assessment. So these are the routine right heart catheterization data. So right RA pressure of more than 15, it's a chance of RV dysfunction is high. And then we need to see the PA systolic pressure. If PA systolic pressure is low, less than 15, then again the chance of RV dysfunction are high. And then transpulmonary gradient, it should be less than 12. If the transpulmonary gradient is more than 12, means probably there is some intrinsic parenchymal disease, or the patient may develop RV dysfunction. And then pulmonary vascular resistance should be less than 3 Wood units. If it is more than 3 Wood units, then again chance of RV failure is more. And then RA2 pulmonary capillary wedge pressure of more than 0.63. So then also the chance of RV dysfunction is more. But the most accurate and recent parameter which we regularly see is PAPI, pulmonary artery pulsatility index. It takes care both forward as well as backward pressures of RV function. So forward in the form of systolic to diastolic pulmonary artery pressure difference, so which says that is a forward function, and then central venous pressure, it takes care of backward pressure. So it's a pulmonary artery pulsatility index is calculated by systolic 2 minus diastolic pulmonary artery pressure divided by central venous pressure. So then the cutoff of less than 1.85, it indicates that chance of post-operative RV dysfunction is more. And but if it is more, that is especially if it is more than 3.1, almost there is very, very minimal chance of RV dysfunction. And the thing is, even once you calculate this PAPI, it is valid up to even 6 months. So that the data shows that PAPI of less than 1.85 is a highly specific for identifying postoperative RV failure. And then in one study, PAPI of more than 3.1, none of the patient required RV support. So, but the criteria we should the cutoff is 1.85 to decide whether the patient will develop RV dysfunction after the procedure. But there are some even risk scores are being given. So Matthews et al. Developed a RV function risk score. It takes these parameters. One thing is vasopressor requirement, and then AST of more than 80, and then bilirubin of 2 or more, and then creatinine. So if the score of more than 5.5, there is 15-fold greater risk of developing RVF compared to the score of less than 3. So even European Society, Euromax has given one more criteria to calculate the risk of right heart failure post-procedure. So here, that is invasive parameter of RA2 pulmonary wedge pressure of more than 0.54, hemoglobin, and then need of inotropic supports, and the intermax profile, and then echocardiographic RV dysfunction assessment, and then there is the intraop, even cardiopulmonary bypass time. So if the score is less than 2, the chance of developing RV failure is around 11%. And if more than 4, the chance of developing RV dysfunction is 40%. So these are all things we need to consider before assessment of the patient. And then second thing, other valvular heart disease. So we are interested in aortic valve. If there is a mechanical aortic valve, it's a relative contraindication because of stagnation, there's high chance of mechanical valve thrombosis. So ideally, if there is a mechanical valve thrombosis, it's better to replace it by bioprosthetic valve at the time of LVAD implantation. And the second thing is, if the patient having AR, the AR is most important component before identifying the patient for LVAD. Because of the continuous flow, this causes increased diastolic pressure of the aorta, and also it reduces systolic pressure of, that is the pressures in the LV, that causes increased aortic regurgitation over a period of time. So if the patient having more than mild aortic regurgitation, so that is, we have to look for that. That causes two things. So even that aortic regurgitation may form closed loop system, so the pump will be less effective. So though the pump flows are fine, then total cardiac output will be less. So because of these two reasons, we need to correct the aortic regurgitation either by just a stitch repair or replacement, and then even sometimes we can close. So then aortic stenosis, it doesn't require any surgical intervention. Regarding mitral valve, a mitral regurgitation, there is no issue whatever the severity of the mitral regurgitation may be, but if mitral stenosis, it causes low flow situation, and that's the reason why we need to identify the moderate to severe mitral stenosis a relative contraindication. It has to be replaced at the time of LVAD implantation. And then if the mechanical mitral valve prosthesis, it's not a contraindication for LVAD. Unlike aortic valve mechanical prosthesis is a contraindication, then we have to replace. But at mitral, the prosthetic valve, either mechanical or bioprosthetic, it's no issue. And then tricuspid valve, stenosis has to be corrected, but the tricuspid regurgitation, there is a conflicting data. So if there is significant dilatation of the right ventricle, and then especially annular dilatation, tricuspid annular dilatation of more than some 4.5, then only we have to repair, otherwise there is no need to repair tricuspid regurgitation. Any intracardiac shunts, even it is because of the post-PBMV intra-atrial defect or PFO, we have to thoroughly do TE and then all the shunts to be identified and closed at the time of surgery, otherwise it may create right to left shunt post-procedure. And then intracardiac thrombus, we have to identify, otherwise one of the things is the CVA. So the post-procedural stroke risk is more, so we have to see for intracardiac thrombus, especially if there is a patient is having AF and then LAA thrombus, it requires closure at the time of surgery. And then arrhythmias you need to identify, because these arrhythmic patients may cause low flow events post-procedure, and then sometimes some people may require ICD. And then many times the patient with ICD requiring LVAD, they may have inappropriate shocks, especially in a conscious patient. So because of the LVAD, the low flow is maintained, but it will identify the VF and it will give a shock that may be painful. And then previous CABG, we need to know about the graft position, we need to do CT, CAG, and then we need to see for the anatomy of the aorta as well as the graft position, and then we have to plan where to give a graft. And we need to evaluate other non-cardiac conditions also, especially peripheral vascular disease. It's a protocol to do peripheral arterial Doppler as well as carotid Doppler before the LVAD. And then we have to identify all the procoagulant coagulopathies or hemoglobin disorders, usually because LVAD causes acquired von Willebrand disease, and then they are prone, and it causes angiodysplasia of the GI, and then it causes GI bleeds. So then we have to identify and even calculate the Hasbled score before doing the LVAD. And then respiratory, it's mandatory to do spirometry as well as CT chest to identify other lung parenchymal diseases. And then hepatic function, if the total bilirubin is less than 2.5, it's okay. And then transaminases less than 2 times elevation, that is okay. It's more than that, we need to identify other irreversible factors. And then renal function, BN of less than 40 and creatinine of less than 2.5 and EGFR more than 50, they should be okay. And if that is abnormal, so we need to treat them, and then again we need to evaluate them. We have to do routine endoscopy to identify before the procedure, so to rule out other APD as well as the bleeding disorders, and fecal occult blood testing should be done before the procedure. And then neurological assessment should be done. And the nutritional assessment is very, very important in LVAD because they require a lot of support from the nutritional point of view for the recovery. They require long hospital stay, and then they have to cope with the device. So prognostic nutrition index is a one index, so which takes into consideration of the serum albumin or pre-albumin as well as lymphocyte count. And then pre-albumin should be more than 15 mg per deciliter, and albumin should be more than 3 mg per deciliter, and then transferrin of more than 250 mg per deciliter. Then even we have to involve the dietitian, and then we have to prepare nutritionally before doing the LVAD. And then we have to do screening of the malignancy, especially for females. We will do routine pelvic scan as well as mammography before doing LVAD. And then psychiatric assessment and frailty assessment should be done. So psychosocial assessment should be done because whether they are ready for the LVAD or not, patient as well as the patient caregivers, and then there should be some social support system, and then even the patient LVAD coordinator has to educate them before the lifestyle effects of the LVAD and how to be prepared, and those things should be done even before doing LVAD therapy. So there are some risk calculation, that is DTRS risk score. This is with Pulse-Style, that is the first generation LV assist device. So we have to take into consideration of these parameters. So then if the low risk, the 90-day survival is 93%. If it's a very high risk group, even only 18%. So we have to calculate these risk calculators before proceeding for LVAD. And then with the second generation devices, that is a HeartMate 2 risk score, it takes into consideration of age, albumin, creatinine, INR, and then center volume, that is the experience of the center. And then we have this, we can put those values into the formula. And then low risk is less than 1.58 and high risk is more than 2.48. So then we can decide. But the recent 2020, that is with the HeartMate 3, there is a risk score is given by there's Momentum 3 trials investigators, that is HeartMate 3 risk score. It takes into demographic profile, and then labs as well as echo criteria and invasive. Total 6 parameters are there. Demography wise, the patient's age, and then history of any surgery, either wall surgery or bypass graft, and then lab parameters, sodium as well as the blood urine nitrogen, and then echo parameter of LV end diastolic diameter of less than 5.5, and then invasive parameter, that is right atrial pressure was by pulmonary capillary wedge pressure of 0.6. So With this, the low risk patients had almost 91% survival at the end of 2 years. And then the very high risk they have 68% survival at the end of 2 years. So these all things, they'll facilitate us in decision making. So finally, so we have to, before taking a decision of the LVAD, we have to give importance to the patient values, and then her symptomatology, and then preparedness, and then predicted outcomes. We have to see the indication, as well as we have to see for the risk profile of the patient. If required, we need to optimize them, and then with the medical team should be prepared for all the procedure. Thank you.
Excellent presentation, Dr. Nitin. You have clearly elaborated how to select the patient for LVAD. So I have one question. So the LVAD is used for various indications like destination therapy, recovery, and bridge to transplant. Which patients you think is suitable for LVAD destination therapy?
Sir, actually the present data shows that there is no clear-cut distinction between bridge therapy versus destination therapy, because, so especially in US, because of UNOS, there is a they revised once after the Momentum 3 trial has come. So that is well accepted. And then because of lack of donor availability, many of the patients previously destined to be bridge to as a bridge therapy. So because of the lack of donor availability or because of comorbidities, they landed up in as a destination therapy. And then many of the patients who are determined to be destination therapy, and then because of some related pump-related things, or the previously which were not correct patients to be transplant because of other comorbidities, they improved and then they landed up in transplant, that is bridge therapy. So presently, so there is no distinction regarding this one, but it depends upon the mainly patient's willingness. So we have to include the patients in decision making. So whether they want to go for transplant with immunosuppressants, or if the patient is fit for both. And then, but if the patient is having RV dysfunction, then very high risk of RV dysfunction post-procedure. So then transplant should be first choice. And the patient is having pulmonary arterial hypertension. So then this comes into picture. The LVAD is the first option. And then at least still the pulmonary arterial hypertension recovered because of the LVAD, and then if the patient is having issues with the LVAD, and then the donor is available, that is organ is available, then they may go for transplant.
Okay, thanks. One more question. One more question to Madam. I think most of the guidelines must be same, but is there any difference in your setup and whatever he has presented?
Not necessarily, because they pretty much cover the same thing across the countries. Essentially, what one wants to do when you get LVAD is LVAD cures left ventricular failure, or like it can't say it addresses left ventricular failure. It doesn't address multi-organ dysfunctions, or if somebody has irrecoverable kidney failure, LVAD is not going to fix that unless there is a cardiorenal component that's reversible. So the important theme of any preoperative evaluation is, can this patient survive the surgery? Are the risk, comorbidities or the risks that are involved, are they, like, can we mitigate them or not? And that's the primary focus of all the evaluations. All the risk scores or various calculators primarily boil down to how is right ventricle, whatever the way that they present, either CVP to wedge ratio or PAPI, all it's addressing is how is the health of the right ventricle. If a chamber is failing, you will not have forward flow. So that reflects low wedge pressure. And if a chamber is failing, the preceding chamber will be overloaded. That means the CVP is high. So the PAPI is also similar thing. It's like, when you have there is no significant variability between systole and diastole, that means your chamber is not contracting. That's what it essentially indicates. So those are the common themes in anything. If somebody has high CVP to wedge ratio, Essentially what it means is your preceding chamber is carrying the burden because your chamber, the chamber that's supposed to contract is not contracting. Hence, it's not generating forward flow to the left ventricle. And the PAPI demonstrates the same thing. And if your CVP is high, that means your hepatic congestion. That's why all your AST, ALT, these markers are elevated. And if your CVP is high, your glomeruli are not filtrating well. They're congested. So that is what it reflects to be renal dysfunction. But what we do is optimize. Some of the RV is, you can condition the RV, or whether this RV has, the ship has sailed, where no matter how much you optimize preoperatively, this RV is distorted to a degree that it cannot be reconditioned. That's the entire point that he put it up. LV, smaller left ventricles, you put a pump in, you can effectively unload the left ventricle and collapse the chamber and move the interventricular septum more into LV, causing more geometric distortion of the right ventricle, leading to more RV failure. And anything that prolongs the surgery, like additional valve surgery or they have bleeding complications, is going to increase cardiopulmonary bypass time, transfusion requirements. Post-operatively, they're going to bleed. You're going to transfuse. You're going to overload the right ventricle. So these are the common themes. No matter what names somebody is labeled with, the underlying principles are essentially the same. As long as you cover them preoperatively and appropriately assess the risk, that's all it's required for the care of these patients.
Nitin, I have a couple of questions. Right, probably I'll just club everything together. If you look at the indications as per the Intermax, right, the level 1 was patients who are coming with acute cardiogenic shock. Coming from intensive care, that is the most common subset of patients that we come across or I deal with. But again, you also showed that the data for LVAD with these indications is probably not the best. The outcomes are futile. So you have the Intermax 2 and 3. Now, when you have a patient with severe cardiogenic shock, one, can you use a temporary, that's what you said, mechanical circulatory support device, but how would you choose which MCA support would you take, right, for the interim period?
Yeah.
The initial mechanical circulatory support, how would you choose, because you have a whole lot of choice there. Second question, right, just continuing that, right. Choosing one support, does it have technically, any kind of a drawback when you want to shift to LVAD?
This is a great point. I don't
sure.
want to. I guess all cardiologists think alike, so I could volunteer myself. So I can tell you, if a patient requires RVAD, probably should not go for LVAD. So that preoperatively. But at the same time, an ECMO patient can still go, provided there is some of the, excessive wedge pressure leading to temporary ventilatory impairment because of the flooded lungs, not because of the intrinsic lung disease, who can be supported with ECMO, but not, the hemodynamically optimized that RV can handle the surgery. You have to be very careful when you pick these patients, especially when you transition someone from ECMO to LVAD, to make sure that their RV can handle post-operative, as he suggested, venous overload, and this is not primary RV failure type of a situation. Okay. If anybody requires bipellas, protective, probably not a good candidate for LVAD, at least not a low volume center. It has to be a pretty high volume center to take that kind of risk. And in terms of left ventricular support itself, so you essentially have tandem and impella, ECMO, as well as intra-aortic balloon pump. Intra-aortic balloon pump, so not all Intermax profiles are the same, to be very honest with you. Like what falls, so our center is large enough to take Intermax zeros. So the Intermax 1 is 1, but we essentially get zeros. Essentially the patient is dying and they still send the patients to us. And it also changes your mindset depending on the age of the patient. If a patient is 25, or like even let's say 30 and there is a wife and 2 kids, how you think about that patient is very different from a patient who is 65. Because most 25 to 40-year-old patients will recover, no matter how much they suffer. Like, their body can handle it. So you will be much more inclined to take them to the OR, even if they are in multi-organ dysfunction. Because you presume all of this is because of perfusion deficiency, and once perfusion is restored, all organ function will recover. And it's also like, hard to lose a younger patient, or at least decline a younger patient compared to, even if it is Intermax 2, let's say, is somebody who is 70-year-old, you would carefully weigh that risk over a 40-year-old Intermax 0.5. So those are the things. And although this is a better classification compared to NYHA class, it is still an Intermax patient who is requiring intra-aortic balloon pump is also Intermax 1, as is a patient who is requiring impeller. And higher the size of the cannula that you have to use, that means the vascular complications are going to be more. And hemolysis, degree of hemolysis preoperatively, impeller would have more hemolysis than intra-aortic balloon pump. So going into the OR, you're going with a higher risk of pigment nephropathy, for example, or vascular complications. And but at the same time, effective unloading preoperatively would be much more better for the RV. So if somebody requires 4.5 liters of support to perfuse the body and to have good organ function, putting intra-aortic balloon pump is not going to do anything to them. So this is all a multidisciplinary discussion between your cardiac surgeon, your ICU team, yourself, and your cardiology team, as well as nephrologists. Like all of these things are, as well as patients and family. What are they willing to accept? Just as Dr. Nitin said. So these are they look. Depending on like how the, it's easy to publish papers and write things in a much more, precise manner than in clinical practice, because in clinical practice, a lot of it is spectrum of things rather than like, there is a lot more heterogeneity than like what we could write in papers.
Dr. Nitin, that was a very, very nice presentation actually. I have taken a lot of points and it's very educative. Only I wanted to know, is any aortic pathology other than grafts, like porcelain aorta or atheromatous aorta, is it a contraindication, or should we consider evaluating that also during LVAD?
No, sir. As such, that is not an obsolete contraindication. But but you need to explain about the embolic risk to the patients.
I think we have got enough hints from the cardiac surgeon to close it and give it over to the cardiac surgical team. Last question before we move on to the next topic.
I'm not going to ask about the pediatric because you don't have that much experience. Just two questions. As per the RV function assessment and the volume assessment, the cardiac MRI is gold standard. So do you consider cardiac MRI over the echo assessment, or you just go by the echo assessment and this?
to have cardiac MRI beforehand. There is no doubt about it. But by the time we get the patients, most of them will have ICDs.
Okay.
So there are ICD compatible MRI systems, but still there is so much shadowing, and most of the time it's the hemodynamic RV assessment that's crucial for us, even more than the echo assessment. Echo assessment is good, and it gives you a lot of good values. I think from echo standpoint of view, the one that on a experience basis, what I could say is LV-RV ratio is a very good indicator. The rest of the indicators that I would take are predominantly hemodynamic RV assessment. If you have CVPs of 3, and even if your TAP-C is like less than 1.5, even like below 1.5, and it's a young patient, we would take them to the OR with a lot more ease than an older patient, because this patient, non-ischemic cardiomyopathy patient, younger patient, myocarditis, or some sort of viral infection type of way, their RV failure is driven by LV failure. Reconditioning the LV will condition the RV as well. So I think again, it's a comprehensive group, multidisciplinary decision rather than like any single parameter.
Okay. And the second question is about the LA appendage. I mean, what percentage of your patients have undergone the LA appendage device closure or something like that?
So a lot of our patients do, if they have not done already, meaning most of our patients have had one surgery before, either CABG, because ischemic cardiomyopathy patient. It's not uncommon these days that they have had like a prior cardiac surgery, either valvular surgery or kind of like a CABG. So they would have had excluded appendage already. If not, it's again surgical preference.
But it is not mandatory to.
It's not mandatory.
Thank you, Dr. Nitin. And before calling upon our next speaker, I would like to welcome Dr. Amresh Rao Mallempati, Professor, Department of Cardiothoracic Surgery, NIMS, who joined us as moderator. Now, I invite Dr. A.R. Krishna Prasad, Director and Chief Consultant, Cardiothoracic Surgeon, Medicover Hospitals, with his topic, Surgical Implantation and Explanation Techniques.
Good morning once again. As I think Nitin has set a perfect stage, few things have clearly come across in his talk, that heart failure is a result of multiple pathologies. So it's a common endpoint of different pathologies ending up in that particular situation. And second thing is very clear from the beginning that it's teamwork. It is not just a cardiologist, it's not just a cardiac surgeon, so it's a teamwork, and the entire team has to believe in that philosophy, physiology, and then only the outcomes will be good. And of course, it's the other important thing is the family and the relatives. This is what we have experienced, is that the moment a ventricular assist device is implanted, we all become one family. And that patient is attached to you for the rest of your life. You cannot say, okay, I've done surgery and he's gone home and I'm good with it. No, they're going to come back and they have lots of, they need support and we need to support them. So I think taking a few steps back and thinking about all these things, and more importantly, what I find is at the time of decision making, we were talking about Intermac 1 and crash situations and very bad situations. I think it is very important, rather than being driven by adrenaline, it is very important for the entire team to have a wholesome idea and divide the situation into the immediate situation before OR and how to manage the patient during surgery, and have a plan for them in the short post-operative period and in the long term as well. Because the whole idea of this implant is not just doing a procedure or finishing with it, it is to make them live for a very long time. So, we need to have that. And the other thing that LVAD does, and we need to remember, is that as the name suggests, it's a left ventricular assist device. I think you alluded to it. We are supporting one ventricle. And this is a totally new physiology for the body to adapt to, because body, we never stop to think about it, although we deal with inotropes and different things. But, right and left ventricle talk to each other, and they adapt equally to a different situation. But now we have changed that equation where we are supporting one ventricle, and the other ventricle has become kind of a slave, or the burden falls on the right ventricle. So it's very important to look at it in that perspective. And in a clinical perspective as well, the flow changes. So from being a pulsatile flow, now it became a non-pulsatile flow. So that has a huge physiological impact in the long term for the patients. Having said that, I'll focus my talk on the kind of devices that are there. I'll not go into very much great detail of what devices we have available at this point of time. And it's okay saying that, there's only one device we can talk about, although multiple devices came into the market. And then I have got a couple of videos showing the implantation technique. Again, it's not a very detailed video. One is supported by Abbott, and one the case that we have done. So let us talk about ventricle assist devices. VADs, again, can be RVAD, LVAD, or BiVAD. But today the focus is only on LVAD. As I said, we are not talking about RVAD or BiVAD situations. We are only talking about left ventricular assist device. And this is very important. We need to know the difference. And Nitin has already alluded to it. Earlier, when the ventricular assist devices started, they were seen as a bridge therapy. They were seen to bridge patients while they are waiting for a donor to come along and give a heart. But now, with increasing technological advances and more understanding with these devices, we could come to a point where ventricular assist devices could be a destination therapy for patients. By destination, at this point of time, we are able to achieve 8 to 10 years of longevity of life if we choose the patients appropriately. And given the statistics of heart failure patients who die within less than 5 years, and Nitin said very rightly, it's like a malignancy. So these patients perish if they are not supported. So this is very good results for destination therapy for ventricular assist device. And with the new HeartMate 3, the longevity of life is almost equivalent to transplant at the end of 2 to 3 years. So we are looking at a very good solution which does not depend on donor availability. A brief word about evolution. The LVADs, earlier ventricular assist devices were bulky. They needed a lot of space, and they had a lot of limitations. But as we evolved, the new HeartMate 3 is a much smaller device. And for the people who are here, you can actually have, you can hold the device, it's being displayed outside. You can see how small it is, and it just fits in the palm of your hand. And the technology has also evolved. So this slide could summarize what are all the devices that have ever been used or are going to be used. But unfortunately, most of them have disappeared except for the HeartMate 2 and HeartMate 3. HeartMate 3 is the latest one, and I'll just go through them briefly through this thing. So I'll first talk about HeartMate 3 because this is of our concern, and this is what we have available in India. Abbott is the company which makes it, or at the moment it's been changed hands from 2 other companies. It's a centrifugal pump. For those who don't understand what is a centrifugal pump, there are 2 kinds of pump we use in heart-lung surgery. One is the rollers, which squeeze a tube and push the blood forward, whereas centrifugal pumps are like they are the floor-mounted washing machines. There is a kind of device that spins, and along with it, it spins the blood, and that is what makes the blood go forward. The difference in this HeartMate 3 is it's got a fully levitated self-centering rotor. So it is actually levitating. It is being lifted in the mid-air. There are no ball bearings. There are no bearings inside the device. That makes the flow smooth, and that makes the chances for hemolysis very less in this device, and that's where it has a huge advantage. And to be honest, the amount of anticoagulation that is required is equivalent to a mechanical valve. So you don't need a huge amount of anticoagulation to run this device, or the patient need not take lots of anticoagulants. And the ability to give large and consistent blood flow, cardiac outputs up to 10 liters per minute can be given. And there is some amount of intrinsic pulsatility, not exactly like a human heart pulsatility, but there is an intrinsic pulsatility to minimize stasis and thrombus. So I'm not sure how much you will be able to appreciate there, but basically there are 8 magnets placed all around the levitating disc, which is seated in the center of the device. And by changing the coupling of the magnets, the device inside rotates, it levitates, and that's what makes the blood being churned. So there is an inflow which brings the blood into the device, and because of this churning action, it is pushed towards the outflow of the device. So because we are supporting the left ventricle, what we need to do is first take the blood out of it and then put it back. So usually the device is placed with the apex of the left ventricle, and the outflow conduit is attached to the ascending aorta. And that's the reason why we had this discussion of previous cardiac surgery and the aortic valve being competent and mitral stenosis. And also the mechanical aspect, we need to understand that the blood is being taken from the apex of the heart, and it is put back into the ascending aorta. And obviously, because it's a motor, and so far the technology has not evolved where we can put a completely implantable device into the body, this device needs a drive line which needs to come out of the body and is attached to a battery system. And the battery system, as again with advancement now, we can give batteries that can last up to 18 hours, but they need recharging. So that is where we are. But 18 hours in a 24-hour day is a good thing for a heart failure patient who were earlier completely either bedbound or very limited in their mobility. So these are all the other attachments that come, and of course they get a set of batteries. So apart from charging their mobile phones, they should also charge their device. Coming to the device itself, it's a very small device. It's only 200 grams in weight. The dimensions are 50 to 55 millimeters, just a couple of inches, this thing. It can operate between 3,000 RPM to 9,000 RPM and can generate up to 10 liters per minute, whereas our cardiac index is about 5 to 7 liters per minute, if in best of the situations. So it can support any flow for the patient. And I mentioned that it's a fully levitated levitating device, and INR is only between 2 and 3 is required. A brief word about other systems. This is the hardware LVAD system. This was actually prevalent, and it is much smaller than HeartMate 3. But unfortunately, it has been withdrawn from the market. So, it's only 160 grams. 17,000 implants have been made, but there were a lot of complications with higher stroke rate and thrombosis. Hence, this device had to be withdrawn from the market. So we don't, unfortunately, have that. Jarvik 2000 is again another device, and Jarvik also makes a pediatric VAD, but this has not yet come into the market. It's still in trial state, so hopefully sometime in future it will come. Again, this is a small device. It's a very good motor. It can generate up to 8.5 liters per minute, and Jarvik 15 millimeters, as I said, can be used for pediatric patients. And in studies, longest patients up to 9.5 years have been, doing well with this device. HeartMate 2 is the predecessor of HeartMate 3, and this device is still available in the market. We can use that in India as well. The difference is that it is a axial flow device, meaning there is a kind of a propelling device or mechanism inside the motor, so which increases the thrombosis rate and the hemolysis rate, and so it's a little bit primitive when compared to HeartMate 3. But again, having said that, it's a smaller device, but this definitely needs creating a cavity in the chest for implantation. But there is robust data for HeartMate 2. More than 27,000 implants have been made across the world. Many have passed the 5 and 10-year milestones. 76.7% survival at 2 years, and around 5% pump thrombosis at 6 months. It's an axial flow VAD, and the dose for anticoagulation is needed to maintain INR around 2 to 3. Again, the weight is it's a slightly bulkier device at 500 grams and needs a thoracic pocket. So with that background of devices, I'm going to only focus today on implantation of HeartMate 3. I'm not going to talk that much on HeartMate 2 because HeartMate 3 is the future, and that's what we are looking at. Nitin has covered about indication, and so I'll talk about approach, preparation, and procedure. As has been mentioned, planning is important. Planning on multiple levels. One is the anatomical planning, for which different kinds of imaging are important, which will give us, the size of the left ventricle, right ventricle, and all the data that we have talked about in the earlier talk. The other important thing we need to consider is the site of driveline exit. So for a right-sided patient, usually we prefer the left side, and for the left-handed patient, right side, so that they can manage themselves. So taking patient into consideration is very important. Again, if they had any previous surgeries, be it abdominal, chest surgeries, or scars, these need to be taken into consideration. And folds of the skin. Many a time we don't consider this as important, but when patients sit, or when they are standing, or when they're in a relaxed position, the abdomen folds, and we never think of it. But it is always better to think about these folds, and particularly in obese patients, they could have extra folds. So having the exit line coming through a fold increases the risk of infection and other complications. Timing of surgery, we talked about it, and sometimes patients might give us time, but sometimes it might be on an emergency patient. And more importantly, counseling of family and patient is a critical thing. No matter how much we talk and how much we counsel them, there will always be surprises at the family end. From our experience as well, despite doing a lot of counseling and talking to them, showing them videos, still they would be unhappy about few things at the end of things, which is quite common because this is totally new experience for them as well. Coming to the preparation of the patient itself, so if we have time and it is like an elective decision, then it is better to have a gut preparation with laxatives and probiotics, which because in the immediate post-operative period, there could be periods of hypotension, there could be period of sepsis where patients might, if they don't have proper gut preparation, it can lead to more worse complications of sepsis and other complications. And skin preparation with antiseptic showers for as long as possible for patients who are, again, elective. And skin markings by identifying folds, we talked about it. And having a discussion with the patient is very important. And dietitian, Nitin also already mentioned, giving them high-protein diet and preparing them for surgery and a long haul in the post-operative period in the ICU is important. And optimization may not be possible in certain situations, but we need to try to the best extent possible to optimize the patient before subjecting them to surgery. As far as surgery is concerned, it is a mechanical thing. As cardiac surgeons, we do most of surgeries day in, day out. So fitting a device is not a big deal. But it is the preparation before, and it is the post-operative care that determines the outcomes. That is what we need to recognize. Approaches-wise, technically, we can say we can do this surgery in two ways. One is sternotomy, and the other is mini thoracotomy. We have performed only through sternotomy, but mini thoracotomy is a revelation to me as well. Apparently, we can do do HeartMate 2 and even HeartMate 3 through a mini thoracotomy on the left side. The apical device can be fixed. The conduit can be passed to the ascending aorta, and with the second space incision on the right second intercostal space, you can anastomose the ascending aorta with the outflow conduit and putting the patient on femoral bypass. And there are certain papers that describe of doing the procedure off pump as well, on a beating heart, off pump. Well, but that's for some other day, I think. But the easiest, and for beginners or units which are trying to do it best, sternotomy gives the best access. We can do all the procedure through one incision, and it is classic. And any associated procedure, as we spoke about valves or anything else, it will be done easily. adding mini thoracotomy, although it might be cosmetically good, the only advantage I see is if the patient needs a future procedure for some other reason, then mini thoracotomy could be of some use. But otherwise, this is a difficult situation we are talking about. Adding further difficulties on surgical front does not make sense. Coming to the procedure itself, chest and abdomen and both groins are prepped. And as I said, median sternotomy would be the classic approach. And maximum dissection should be done before heparin. Now, this is something as a surgeon, even I had to stop and learn. When we did the procedure, the meticulousness with which the hemostasis was done was beyond what we usually do. The focus is on doing the main operation, but here it is a different ball game. Every single bleeder can prove very detrimental in the post-operative period, because once the device is implanted, there is no reversal with protamine. There is only, you're going to give heparin for the rest of their life, heparin and acetrom for the rest of their life. So any small bleeder will haunt you like mad in the post-operative period. So I cannot again emphasize how much meticulous you need to be about maintaining a hemostasis. Operative field flooding with CO2 is again an important point that I learned because that helps a lot in de-airing, because now we have opened all the chambers to air. And rather than having air, it is better to have CO2, which is dissolvable in the blood. So CO2 flooding is again an important component of doing the surgery. Cardiopulmonary bypass is commenced by bicaval cannulation and aortic cannulation. There is no need to stop the heart. As you will see in the videos, there is no need to cross-clamp and give cardioplegia unless some other procedure is required for the heart. And we need to keep in view where you are planning your aortic anastomotic site, the lie of the graft, and creation of a pocket for the device. All these things should be planned before we set out to do the procedure. Again, some more tips. Less diathermy to the skin, because dead patches of skin can again come back and haunt, and this could be focus of nidus of an infection. And I'm sure Dr. Kumar is here. He'll appreciate how bad it is to have a prosthetic pacemaker inside and having an infection. It is really difficult to get rid of it. So our focus in surgery and immediate post-op is to make sure that there is no infection at all or chances of infection. I mentioned meticulous hemostasis, careful cannulation and accurate cuts. Again, no random cuts, because they can bleed, and purse strings should be taken very carefully. I'm mentioning this because as cardiac surgeons, we tend to not think about these steps in many situations. We just go ahead doing them because we know we can control them when we come back. But here, a little bit of preparation is required. So here I think I'll go through the video and then, okay.
Every case we seem to hopefully displace as much air as we can.
To prepare the coin knife, cut the ligature securing it and remove the plastic plugs from each end. Then place the handle through the hole in the knife cylinder to make a T-handle. In preparation for attaching the apical cuff, elevate the apex of the heart with lap sponges.
Every case we seem to
So here, I've already started the video when the patient has been put on a cardiopulmonary bypass. The order is a little bit different. You can put the driveline before or after. The order here seems to be a little bit in the different way, but it doesn't matter. Oh, sorry.
Every case we seem to hopefully displace as much air as we can.
To prepare the coin knife, cut the ligature securing it and remove the plastic plugs from each end. Then place the handle through the hole in the knife cylinder to make a T-handle. In preparation for attaching the apical cuff, elevate the apex of the heart with lap sponges and place the patient in steep Trendelenburg position.
Herniated three-sewing cuff designed with a little bit of concavity to it so that it can't evert, which would make it challenging for the pump to engage onto this flange. I think it's important that your sutures go at or near the black line. If they come out here to this area, there's a potential space where you could have leaking. So if you look at this, the black line is close to the flange. I like to aim the center of this right on the true apex.
The apical cuff can be affixed to the left ventricle by two methods, sew then core or core then sew. If using the core then sew method to attach the apical cuff, first locate the coring site on the left ventricle. It should be at the apex and lateral to the left anterior descending coronary artery. The surface of the heart may be marked with the edges of the apical cuff to facilitate proper placement of the sutures. Then core the ventricle using the coring knife. Align the orientation of the coring knife toward the mitral valve, taking care to avoid orienting the inflow cannula towards the interventricular septum or free wall. Device function will be compromised in the presence of inflow cannula obstruction. Apply the cutting edge to the epicardium and maintain pressure while rotating the knife until the ventricular cavity is entered. Caution: do not allow the knife to involve the ventricular septum while performing LV coring. Inspect the ventricle and remove any mural thrombi or trabeculi that may impede flow into the pump. Using either a full back stitch or partial back stitch, place 12 pledgeted sutures almost full thickness, approximately 7 millimeters from the core to align with the black line on the apical cuff. The sutures should be positioned so that the apical cuff will lie directly on the epicardium and not on any of the pledgets. This will prevent protruding myocardial tissue, allow proper engagement of the slide lock, and ensure hemostasis. With a metal ring of the apical cuff directed away from the heart, apply corresponding sutures to the felt cuff, targeting the black circumferential line on the apical cuff. Ensure the sutures do not traverse any of the metal surfaces of the apical cuff, as this can be a potential fatigue site for the suture. The sutures are tied tight with 6 to 7 throws on each knot to gather the myocardium around the apical cuff and to help ensure a hemostatic connection between the cuff and heart muscle. Care is taken not to over-tie and tear the muscle. Ensure that the suture knots will not interfere with the apical connection. Alternatively, the sew then core method may be used, where the apical cuff is attached to the left ventricle prior to coring. Locate the dimple of the left ventricular apex and the left anterior descending coronary artery as anatomic landmarks prior to attaching the apical cuff. The location should be at the apex and lateral to the left anterior descending coronary artery. Place a minimum of 12 horizontal mattress 2-0 braided non-absorbable sutures with large pledgets almost full thickness adjacent to the outer edge of the apical cuff and through the black circumferential line on the cuff.
I'll put 4 of these in at different areas first and tie them before I put the rest in. If the sutures are too lateral, there may not be a good seal to the heart. So the proper technique is ideally to bring your sutures up within the black mark, closer to the center of the appliance itself.
Sutures may be placed in the 4 polar quadrants and tied down to center the apical cuff over the LV apex before placing the remaining sutures.
This is going to put sealant on this. I think it does fix up some of the needle holes. You have to be careful that you don't get it involved in the mechanism which is there to engage the pump. So I'm going to put some glue around the outside. I will not put it on top of the ring.
If a sealing agent is used on or near the apical cuff, ensure it does not interfere with the slide lock mechanism.
So now we're going to get ready to create our core and put the pump in position. So let's grab the pump here. I found it easier to attach the outflow graft first, so I'm going to do that now. Can I have the outflow graft, please?
Prior to connecting the outflow graft to the LVAD, make certain that the thread protectors have been removed from the pump outlet and the outflow graft. Attach the proximal end to the pump, hand tightening the metal locking screw ring clockwise until a clicking noise is heard. Then continue turning until it's tight and will not turn any further. Do not use tools or other instruments to tighten any connections. Hand tighten only. Slide the bend relief over the graft, leaving it disengaged. Then place a cross clamp on the outflow graft, avoiding the bend relief. Never clamp the outflow graft bend relief. This could cause a kink, which might lead to abrasion and blood loss through the graft.
We're going to take our core out now.
Cuff and core the ventricle as previously described, being careful not to involve the ventricular septum.
Let's look at the core. Make sure you have the full piece of the core. There was no thrombus on it. You haven't lost any piece of it. Then we'll look inside of the ventricle to make sure that there's no trabecular muscle or anything across it that we have to get rid of. And I see one little bend. I'm pretty aggressive about getting all this stuff out so that it doesn't get ingested in the pump.
The ventricle is inspected for any neural thrombi or trabecula that may impede flow. These should be removed. The 6mm skin coring punch supplied in the implant kit is used to create a circular incision at the exit site just below the costal margin in the mid-clavicular line. The position of the exit site should not interfere with clothing. The fat is cleared and the anterior rectus fascia is identified and scored with cautery. The tunneling lance allows the option of tunneling from inside out or outside in. If using the tunneling handle, connect the handle to the tunneling lance by retracting the handle flange and inserting the tip and hexagonal feature until it is captured in the handle. Then release the flange. The tunnel is created by blunt dissection and should be as long as possible to maximize ingrowth along the pump cable's polyester velour cover. When tunneling inside out, with the driveline exiting on the right side, insert the tip of the lance into a small incision on the inner abdominal wall, and advance the tunneling lance through the anterior rectus sheath, creating a long and gentle curve from the inferior aspect to the external circular incision. Bring the pump up to the field and confirm the pump cable tunneling adapter is securely connected. The yellow line will no longer be visible when it's securely connected. Insert the tip and hexagonal feature of the tunneling lance into the tunneling adapter and screw the middle nut down tight. Advance the tunneling lance until the pump cable is exteriorized. The driveline has been designed to allow for velour or silicone to cross the exit site. Once the pump has been implanted, the driveline should lie along the diaphragmatic aspect exiting the pericardium into the subcutaneous space near midline with no acute angles or hinge points. Disconnect the tunneling lance from the tunneling adapter by unscrewing the metal nut. The tunneling adapter should remain in place to keep the pump cable connector dry. Wrap the pump in an antibiotic-soaked lap and place it in a secure location on the sterile field. Prior to inserting the inflow cannula through the apical cuff into the left ventricle, fill the heart with blood. Verify the slide lock is retracted as far as it will go so it is fully opened. And remove the glove tip from the inflow cannula. Proper orientation of the inflow cannula is critical. The opening should be directed toward the mitral valve and away from the interventricular septum and free wall. The ideal orientation will anticipate that the dilated left ventricle may shrink as its workload is assumed by the LVAD. Rotate the pump so that the outflow graft is directed to the midline of the thorax and the pump cable is oriented toward the midline. Insert the inflow cannula into the ventricle through the apical cuff. Once the pump is fully seated onto the apical cuff, push the slide lock inward to engage and lock the pump into position. The lines on the slide lock will no longer be visible when the locking mechanism is fully engaged. Gently pull on the slide lock to ensure it is properly engaged. Remove the lap sponges and slowly place the pump down into the pericardium. To de-air, either vent the aortic root and or insert a vent needle into the outflow graft below the clamp at the highest point in the lumen on the anterior surface. Never place the vent needle through the bend relief. With the aortic clamp still in place, remove the clamp from the outflow graft. Then fill the heart sufficiently to allow blood to flow through the ventricle into the LVAD, an outflow graft for de-airing purposes. Once the graft is de-aired sufficiently, replace the cross clamp on the outflow graft and slowly remove the partial occlusion clamp from the aorta. During the de-airing process, always monitor for the presence of air in the aorta and left heart using intraoperative transesophageal echocardiography and keep the left heart full. Warning: prior to initiating pump activation, all entrapped air must be removed from the left ventricle, LVAD, and outflow graft in order to reduce the risk of air embolus. The surgical field may be flooded with sterile saline or carbon dioxide to further minimize the risk of air entry. When all air has been removed from the blood pump, it is safe to increase the pump speed.
So, I think that was a self-explanatory video. This is from our case, what we have done. So, some of the things that I was really surprised was the size of the hole that we made in the LV. You know, usually if we make a stab itself, we are worried, but it was a big hole, which which I thought might cause problems. But the size of the device is such. And the other thing that had happened was, as in the previous video, during the clearing of the trabeculae, there was a small piece that fell into the LV. And we had to search for the next 10-15 minutes to retrieve the piece, because we cannot leave that. That can cause obstruction of the pump mechanism. So we need to be absolutely sure that nothing else is there. Inspect for any thrombi and any other possible things that can occlude the pump flow. So once that is completed, then we have started taking the sutures. Again, the sutures are taken very widely. So in the end, once we are done with the sutures and a device is placed, you should be able to see a donut of myocardium between the Teflon cuffs and Teflon pledgets and the device. Give good hemostasis. Not So the device was placed, and then we click that into position. There is a rod that is given if, say, for instance, you want to take it out. Again, you can take it out and put it back, so that possibility is there. Now, this was not covered in the previous video, but the proximal anastomosis is made on the kind of right curvature of the aorta so that the lie of the graft is good. And the lie is, as was explained in the video, it comes all along the diaphragmatic surface, past the right atrium, and on the right curvature of the ascending aorta. So, yeah, before this, okay, we finished that, sorry. Yeah, as I said, what was scary in this case, what was different was the size of the LV hole, and as I mentioned, there was a missing piece of myocardium when we were clearing the trabeculae. And despite me looking at this device before the procedure and holding it in my hand, at the time of implantation, it really looked big for the heart and the chest cavity. You know, that is something that only you will experience once you have it in context of the chest. And as soon as we started coming out, we saw on the TE there was a kind of a fold that was coming closer to the device, and it looked like it was the LA appendage that was folding in, but it was actually the LV was so big that the LV folded into itself and was pushing the mitral valve. So again, this was something that we didn't expect that would happen. And the length of the outflow graft always ends up longer because the dacron kind of stretches. These are the things that we learned. Nitin is going to talk about the case that we have done, or the patient. The patient had a normal right ventricular function preoperatively, and otherwise there was no evidence of PAH and all. But despite that, we ended up using milrinone, and we had to monitor the RV function for at least the first 1 week post LVAD implantation. So that brings back to the point that, although we are supporting the left ventricle, the right ventricle suffers, and it takes a while for it to get adjusted. So even a normal RV function, patient might struggle. And so you can imagine if someone is having a bad RV, that can hamper the outcomes. And weaning of each support, inotropes, ventilator monitoring, and CPAP was entirely different with this case. We had to go absolutely slow and take the patient in recovery into consideration. And dependence on milrinone and sildenafil, again, I cannot emphasize. I was surprised that I thought RV will just sail through. But at one stage, we weaned it off, and then again, we had to bring it back because we thought the RV might be distending. So we need to be slow and understand or make sure that the RV is recovering following LVAD implantation. Patient had a small stroke, and this was again, the patient was completely heparinized, except for a few hours when the ACT went down very briefly to around 1. But apart from that, there was no period of, where the APTT was low or INR was low. But despite that, patient developed a small stroke, and luckily, because it was a small stroke only involving the right upper limb, she completely recovered from that. And again, delicate INR management. Pleural effusions was another complication that we had, but we could manage that with medical this thing rather than put chest strains. Psychological effects, again, as I said, we counsel the patient, relatives, but their level of acceptance was totally different. They wanted the patient almost like to be walking in 2 to 3 days once the LVAD was put. But they did not understand what was the situation before. And when the patient was almost in the ICU for 7 to 10 days, and I think 10th or 15th day, we started mobilizing her into the chair and started moving. So they were completely depressed, relatives. They didn't expect that. So it takes a huge effort. And of course, it was team effort. In the post-operative period, the critical care team, the nursing team, the dietitian, the cardiologist doing daily echoes, all these things played an important role. So it's not just doing the surgery, but it was, in the end, it was worth it. Because the patient is doing well, now less dependent on the hospital. Otherwise, she was just having frequent hospital admissions. A brief word about explantation, because my topic has been this thing, and this is very rarely spoken about. Some of the patients, once we put the LVAD in them over a period of time, in maybe few weeks, 4 to 8 weeks or 2 to 3 months, their LV might improve, and there might come a point where the LV size has come down and they no longer need it. Otherwise, most of the explantations are at the time of transplant. Very rarely it is because of the recovery of this thing. And this study I could come across, which was called Restage HF, and the study was done between 2012 and 2015. So at that time, HeartMate 3 was not there. So the study patients only had HeartMate 2 implants. And what it had shown is that 40% of enrolled patients achieved primary endpoint, with 50% of patients receiving the protocol being explanted within 18 months of the implant. And their end diastolic diameter had come down to 4.8 from initially where it was much larger. And end systolic diameter also had come down to 3.5. Wedge pressure, and overall all the parameters which we talked about for implantation had come down. So these were their explantation criteria. So when do we think of a patient who already has a LVAD? When can we think is when their end diastolic diameter and end systolic diameters have come down, EF has improved more than 45%, And the evaluation in this study has been done when the LVAD was on at 6,000 RPM, and for 15 minutes they did try all these criteria. And resting cardiac index was more than 2.4 liters per minute, and maximum oxygen consumption with exercise tolerance of more than 16 ml per kg per minute. And post-explant, 77.1% patients survived up to 3 years. So that's again good data. So there is a chance that these patients will get better. And the technique itself can be done through sternotomy, and in case of HeartMate 2, we can do it through mini thoracotomy. And there is something like called decommissioning. I'll mention that in a moment. So complete explantation by dividing the inflow conduit that it can be done off pump, and leaving the outflow cannula also can be done. And decommissioning in HeartMate 2 can be done by deploying an amplatzer device. So without actually having to subject the patient to another surgery, you can just go and put an amplatzer device in the inflow cannula, and that would block the device, and the rest of the LV can be working. But this is associated with more complications. For HeartMate 3, one of the Indian companies, actually I was surprised that there's an Indian company in collaboration with Germany has come up with this device which goes and plugs the LV inflow, and this again can be done on beating heart. So, but it's a surgical procedure which needs either a sternotomy or a thoracotomy. An outflow tract can be either removed or can be left alone, or it can be dissected and closed. There's something called as a decommissioning of device. Again, I'm not sure whether it's possible with HeartMate 3, but with devices like HeartMate 2, we can decommission. That means we don't take the device out, but we leave the device and make it redundant. And this can be done without the need to arrest the heart, and this is followed by exposure and ligation of the outflow graft, and severing the drive line and leaving the device in situ. So we just cut the drive line and leave it there. A hybrid decommissioning procedure has also been described by occluding the circuits with the use of percutaneous vascular plugs to avoid the need for chest re-entry. I'm not sure whether we've reached this point, but yes, with increasing number of LVAD patients, maybe we should be thinking about how to deal with this in future. But that was for the closure of this topic. Thank you.
Very nice presentation, sir. Just one thought. When we operate on, say, ischemic VSDs and we do a ventriculotomy, start with a small one, but by the time we end up with the surgery, it becomes big. Do you have any such issues here?
Yeah, that possibility is there. We should be very careful. But here in the case that we have done, the coring device is an excellent device. Actually, it's a very sharp knife, and it doesn't. It cuts very easily. It can cut your skin also if you are not careful. So it's very. You should handle it with very carefully. So it's a very precise cut. But I agree that possibility is there when you're looking for intracardiac thrombus removal, or when you're trying to clear the trabeculae for the implantation, that possibility is there. But again, the way we have taken the sutures, you take very wide sutures and Teflon pledged to prevent the cut through. And the tension that is placed is also very minimal. You need not tie very hard. Then yes, otherwise they will cut through. And if it's depending on the situation where we are using, the myocardium is very friable, that possibility is there. That's why the tension with which we have to tie the knot should be just optimal.
So that is hard-fed you have used?
HeartMate 3, yes. Teflon pledged.
Hard-fed or soft-fed?
Soft.
Another question I wanted to ask was, if there's any scar, would you want to kind of ligate the scars, or
No need to do that, sir. See, the idea here is I wanted to stop there, but my video is not cooperating. The inflow should be facing the mitral valve at the end of the procedure. As long as you achieve it, it doesn't matter. And in our case, as I described, although the myocardium was all intact, there was no particularly scarred area, the ventricular myocardium kind of folded itself. And so in the end, the cavity size was small. So even if it is scarred, it doesn't matter. If you feel it's going to interfere with the mechanism in some way, it can occlude, you can always placate it.
Regarding your first question, the center hole and the pledget where we put, there is a lot of gap, almost 1 centimeter or more than 1 centimeter. So less likely to cut through there. Even if it cuts through, you can put a pledget extra and do it. Yeah. And I think second question, I think the indications will be totally different. If it is aneurysm, we have to do aneurysm or LV reconstruction. And in that case, LVAD is not required. LVAD is mostly for the dilated cardiomyopathy or thinned out ventricle, not for the LV aneurysm.
Again, I want to give the disclaimer, I'm not a surgeon, but hearing from our surgeon, because it's all multidisciplinary discussion, so we kind of get involved just to give cardiology standpoint of view. The scar is a better thing actually when you go, because some of the acute MI patients, when they come in, they will have mushy myocardium, especially with LAD infarcts. So at that point of time, even like the pledgeting is very difficult, and the coring itself can like so that's the reason why surgeons want to wait out if they could on temporary support until the time apex scars out. Usually they prefer like 90 days or so in like massive anterior wall infarcts which could not be revascularized or no option for revascularization. So that is what they usually ask for. Actually LAD infarcts, like where
Okay. Thank you very much. In view of time, I think we planned the tea break around 11:30, so that we can have lunch at 1:30. So we thought we could break for 5 minutes, and then come back 5 or 10 minutes max, and then come back and listen to Dr. Mridula, and then we can carry on till lunch. Otherwise, what would happen? This coffee will affect the lunch. So. No. I think many of us are waiting to listen. What you're going to tell us. Just 5 or 10 minutes, quick coffee break, and then we'll assemble again. Thank you.
So we continue with the next session. I take this moment to introduce to you Dr. Mrudula Reddy, the Co-Medical Director, Heart Failure and MCS Program, Miami Transplant Institute, Jackson Memorial Hospital, Assistant Professor of Medicine, Miller School of Medicine, and she has been a heart failure and transplant cardiologist at Newark Beth Israel Hospital, Integris Baptist Medical Center, and as a medical director, heart failure, pulmonary hypertension and MCS program at Oklahoma Heart Institute. It's an honor to have you, ma'am. And I invite the moderators for the session, Dr. Ram Subramanian, Dr. Amresh, Dr. Balaji, Dr. Ghanshyam, Dr. Kumar Narayan. I invite Dr. Mrudula Reddy to please present. Thank you.
Should I proceed? Do I need to open my presentation or how does it work? Well, thank you for having me here. I want to thank everyone, Dr. Krishna Prasad, Dr. Sharath, and Dr. Nitin for inviting me to speak. It's a pleasure and it's an honor to meet all of you and to have this opportunity to speak to you guys. My first topic is post-operative care of LVAD patients. This is to facilitate enhanced recovery after surgery. This is a kind of a concept in most of the cardiac surgery. This has also spread into LVAD and transplant world at this point of time. This predominantly came through like cabbages and valve surgeries to facilitate early recovery and mobilization and reduce the length of hospitalization, as well as reduce the mortality and morbidity associated with surgery. So what exactly is enhanced recovery after surgery? It's a synergistic care across the spectrum to facilitate, as I said, like to recovery and early mobilization. And primary thing to facilitate early recovery, as the prior speakers mentioned, is the patient screening and selection. Appropriate patients, when selected appropriately, obviously will recover faster. And at least you would know what the recovery times are going to be. If you're taking high-risk patients, at least you can go with a plan and have a reasonable conversation with patient and family beforehand what to expect. So preoperative optimization is a key to ERAS program, and plan for intraoperative and postoperative recovery or management based on the risk factors, whatever the risk factors and risk assessment of this patient would be helpful to mitigate the risk. Multidisciplinary care and care coordination is a very, very essential component to move the patient along. Early mobility as well as ancillary support is crucial. Ancillary support with nutritional services, as well as your PT, physical therapy, rehabilitation, and occupational therapy. Disposition planning and care coordination. One of my mentors used to say, like, your plan for discharge starts the day that patient comes to the hospital. So you should always have a plan, whether it works out or not. Preoperative assessment is essentially what are the impediments that you're going to face. It may not always go in the way that you plan, but at least to have a plan is essential so that you can identify key elements and barriers along the care and mitigate those issues beforehand. So clear identification of team leads and communication channels are very, very essential, because you don't want to get into arguments with your ICU team and CT surgeon within 24 hours of the surgery. So you need to have who wants the patient and what period of time. So immediate post-op, it will be CT surgeon's field for whatever the length of the time that they choose. that it's not necessary that every system should follow the same, but depending on the maturity of the systems and strengths and weaknesses where their resources are, to have that is very essential. Who is going to own what? Who is going to call who? If you don't have that plan, there will be confusion among the frontline workers, as in nurses. Who is the point of contact? It would be best to have the ICU team as the point of contact, and ICU team physician to make the decision on which path, who to call. I think that works out for most institutes. Again, some surgeons may want, like, it's completely my field for 72 hours, 96, whatever the time period that they chose. And whatever that one may choose, it would be good to have the identification of who is the leader, who is the person that needs to be communicated, and how that channel of communication works. They might look very simple when you hear, but from practical standpoint of view, they play a key role. So what is a post-operative goal that one has? Early extubation, delirium prevention, opioid minimization, volume optimization, RV management strategies. You would need to have a plan for renal dysfunction, especially if you're taking borderline creatinines into the surgery. You should be prepared to do CVHD early so that some sort of renal replacement therapy early on to facilitate essentially prevent the renal failure, fulminant renal failure and dependence on dialysis. Because if a LVAD patient ends up on dialysis, even in United States, it's not easy to find a dialysis center to accept an LVAD patient. So it would be something that requires, pre-planning. And if you're expecting a patient to go into renal failure, even if it is temporarily post-operatively, a young patient with Intermax 0 or 1 profile, prepare for that early on. Don't wait until the time, when CVP is hitting like 20, just plan it early on so that you facilitate the renal recovery, so-called, at that point of time. Glycemic control, optimal nutrition, patient engagement. Again, the education should start preoperatively, but even after surgery, the nurses, everyone that's involved in the care should educate the patient as much as possible, and their engagement is actually what leads to success. Early mobility is very important, but it has to be done in a supervised manner because these patients require external precautions. Last thing you want is a dehiscence and malalignment. You don't want such complications. So there has to be, the best thing for all of these things to work well is to have protocols. Protocols and institutional policies that leads to success and prevents guessing and every team member doing their own thing is not going to be helpful for coordination of the care and for the patient outcomes. Prevention of thromboembolic events is very important. So there are different types of thromboembolic events. These are post-op patients who can develop DVTs and PEs, but these are also the post-operative patients who, if they have an ingested thrombus, they can have central neurologic events. So you got to be careful, but at the same time, you have to weigh against the risk of bleeding. So those are key things to consider, especially with HeartMate 3 patients. We don't necessarily anticoagulate post-operatively and go straight to Coumadin. Again, it depends on institutional strength and what the protocols are, how one feels comfortable about it, and the patient's own risk that defines their probability to have a thromboembolic event. So you have the luxury of Swan-Ganz catheter post-operatively, and you will have a lot of data to work on. You have LVAD parameters, you have hemodynamic data, you would have blood gases, you would have frequent metabolic profile that you could follow through to optimize the patient and facilitate recovery. And sometimes you still need an echocardiogram to decide what pathology patient is experiencing and address it appropriately. And renal function as well as urine output, one needs to carefully monitor post-operatively. Management of arrhythmias is crucial in these patients, especially during post-operative phase. Some of them will not be affected by arrhythmias and some of them will be affected by arrhythmias. So it's key, the key thing is to differentiate whether it's a hemodynamically significant or insignificant arrhythmias. And there are factors that influence that decision, and we can discuss as we go along. So one of the very important things to understand for any LVAD patient is LVAD, while it supports the left ventricle, it is a preload dependent device and afterload sensitive device. That means if your left ventricle is not going to fill, no matter how high it runs, it can't pump the blood that it does not receive. If your RV is failing or you're tamponading and your left ventricle is not filling, there is no way this pump can generate miraculously some flow that it doesn't get. So it's a preload dependent device and afterload sensitive device. What it means essentially is if you are hypertensive, especially centrifugal pumps are much more sensitive to afterload compared to axial flow pumps. You have to maintain their maps between 65 to 85. In postoperative phase, we are okay even if it is 55, 60, as long as end organ perfusion is not affected and patient is neurologically intact. It's not the absolute number that you need, you actually need the whole picture in the management of these patients. If somebody's map is like 58 and their flows are 4 liters or even 3.8, 4 liters, and their creatinine, they're making urine neurologically intact, there is no reason to keep going up on pressors to maintain higher maps because it's essentially going to lead to limb ischemias or some sort of like essentially your radial artery, distal perfusion will be affected due to higher pressor use. And that's very key thing rather than just focusing on numbers, you have to focus on the whole picture of the patient. And what you can change and what you cannot change is also something that needs to be assessed carefully. Meaning, if somebody is generating 3.5 liters and you did an echocardiogram and their LV is like balloon, you just need to crank up the speed on LVAD and unload the LV adequately. So, at the same time, if you're running at a higher speed and your septum is pushing into the LV, you have to down titrate the speed. How to manage and optimize a post-operative patient is kind of it's an art of medicine. It comes over a period of time, and each patient is definitely different from one another, and that comes with time and the experience on how to manage these patients. Also, the other thing to consider is most of the time when we discuss the pump parameters, how they change, we only talk about intra-pump hemodynamics and pump and essentially vascular, as in blood pressure measurements and swan measurements. But there are other things that affect these pump parameters during post-operative period, even in late stages. That's the mediastinal, essentially what their intrathoracic pressures are. That's affected by their ventilatory mechanics, as well as essentially any pleural effusions, any other like intrathoracic changes that can happen if they are having hematoma, pericardial hematoma, that can affect the pump parameters. So it's very important to know both extracardiac and intracardiac and intrapump dynamics and how the interplay of these mechanics that are going to affect the pump flows or pump hemodynamics in general. So that's the reason why it's very essential to understand what the LVAD pump parameters mean. The speed is the only thing that we can control in the LVAD. As you crank up the speed, you unload the LV. As you down titrate the speed, you actually essentially don't unload the LV as well. So the flow is not a measured number. This is not, unlike Centrimag, where there is a true flow probe, where you're measuring the actual flow, LVADs it's an arithmetic equation. Depending on the speed that you are running the pump at, you're calculating with this amount of energy that pump is consuming, and at this RPMs, this is the calculated flow. This flow is not a measured flow, so sometimes that needs to be kept in mind when we are changing the management of the patient. And other thing is, very important thing is the pulsatility. PI that we see, it's a little bit of a complex thing to understand, but the easiest way to look at it is the variability of the flow within the pump. That is what is represented by pulsatility index. So the kind of like a little easier way to understand is the difference between systolic and diastolic flow. It's essentially a native heart contribution of native heart versus the pump itself that contributes the variability of the flow. But at the same time, you have to think about the preload conditions and afterload conditions. In the event of stable preload and stable afterload, this is primarily driven by contractility of the native ventricle. If you have higher PI, that means that your pump is able to contract and push the blood. That's why you have the variability between systole and diastole. And if it is not the case, if you are hypovolemic, you will not have that variability just because you're underfilled. And you will have significant variability if you have very high resistance. Since your afterload is high, that's the reason why the variability of flow during systole and diastole, because it has to overcome higher resistance, and that's the reason why that change in the PI exists. So anytime when the PI is high, you would have higher variability. That means either the patient is hypertensive or the patient is recovering. Those are the two probabilities. And if the PI is low, that means LV is underfilling somehow. Either it's because of the tamponade or RV failure or bleeding. That is clinical assessment that you would have to do post-operatively. If someone's chest tube output is a lot, then it's likely hypovolemic, and you have the Swan-Ganz catheter to see what your right atrial pressure is and what your wedge, whatever hemodynamic condition that exists. The key place where you need echo is between the RV failure and tamponade, because hemodynamically they both would look the same. The way you could differentiate is by echocardiogram at that point of time. If it is septum RV, dilated RV deviating into the left ventricle, that's a different story, which is RV failure, and your treatment is going to be different with inotropes, volume optimization, and additional diuretics, versus if it is tamponade, then you have to call your surgeon fast. So those are the key things that we need to know about pump parameters in the post-operative management. So in a maturing system, in a system that's not yet matured, it's good to have a method of documentation so that you don't miss key parameters or what is the change or the trend that's going on. Whatever the method that one wants to document and whatever the frequency one wants to document, just have a plan. Like, this sheet might work out for some people and it may not work out. Like, whatever the form of documentation of these parameters that you would want to have, it would be good to have the documentation to see how the sign out goes from one to other person, or at least the documentation to know the trend. So, and what are the post-operative complications that one sees? Bleeding is the most common complication, and this is the one that actually the surgical colleagues do not like the most because they have to take them back to the OR. And especially in US, they're basically measured against return to the OR, so they would not want to do that. Sometimes that's the time that you have to arm wrestle at that time. No matter if somebody is bleeding, you have to plug the hole. No matter what I do, how much I transfuse, that's not going to play. You need to plug the hole type of a thing. So those are some conversations, some tough conversations you would need to have. You would want to keep your CT surgeon as happy as possible, except when patient is bleeding and they're not taking them to the OR. That does happen in US. They want to transfuse as much as possible before they take them to the OR. and right ventricular failure, because that follows the bleeding, because if you are overloading with the transfusion, then what might be mild to moderate RV dysfunction can lead to fulminant RV failure. Sometimes you have pre-existing RV dysfunction that could go to RV failure, so that's one of the important complications that you would need to be careful. Vasoplegia and vasoplegic shock is a very challenging thing to deal with. So most of the patients, at least in the United States, are on inotropes before they go to the LVAD, because you see mostly Intermax 2, 3, and 1 cases that go to the OR. There are few Intermax 4 and very few 5. What happens is milrinone is an inodilator, so these people go into the surgery with essentially dilated vasculatures and exposed to cardiopulmonary bypass and transfusions. So they come out OR with a lot less blood pressure than what you would want, not because of the pump, but this is essentially because of vasoplegia. So one would need to have a plan for how to manage vasoplegia. Actually, the best thing is to avoid it by choosing appropriate timing for the implantation. If somebody is requiring higher and higher doses of inotropes, rather than keep going up on the inotrope, getting them to LVAD or transplant sooner would be better, because this is the same challenge you would have even after transplantation, but it would be a little bit easier to manage in a post-transplant patient versus a LVAD patient with reference to vasoplegia. Higher doses of pressors are going to, again, lead to digital ischemias, and that's not the best thing for the patients to have digits cut off. We have to do it at times, but that's not the ideal thing to do. Tamponade, again, tamponade RV failure, we would have to do echocardiogram to differentiate. Hemodynamic data looks similar. Infection and sepsis, hopefully, again, we use skip antibiotics to kind of prevent early sepsis or any bacteremic phases to avoid the phase of bacteremia, because they have so many indwelling lines and catheters at that point of time. But prolonged use of antibiotics is not recommended in these patients unless clinically indicated. But if there is any clinical, sometimes we treat their bacteremia while they are on temporary mechanical circulatory support and went into the OR, even if they go with clear blood cultures just prior to the OR, ID infectious disease partners usually give little extended antibiotics on those patients, because you don't want the device to be seated, because you're seated, and if the device gets seated, you're not going to explant LVAD because the device got seated, and that's going to lead to a lot of infectious complications and a lot more antibiotic need in future. So we try to avoid, we want to avoid VAD endocarditis as much as possible, because there is nothing that you could do. You can't explant the device unless the only thing is if they're transplantable candidates, you could go for transplant. So that's the reason why you try to avoid whatever you could to prevent the infection in these patients. Limb ischemia does happen, and it's predominantly because of higher dose of pressor in the setting of vasoplegia. For whatsoever reason, if you have to use higher dose of pressors, stroke can happen. Arrhythmias, as mentioned, some are hemodynamically significant and some are not. Hypertension is not a common thing that you see postoperatively, but there are some patients that experience hypertension, and you would want to control their blood pressure adequately. Inadequate LV loading, inadequate LV unloading can happen, so speed optimization is necessary. If someone's flows are running down, it's not always RV failure, it's not always tamponade, it's sometimes just adequate blood pressure control if they're hypertensive. Inflow cannula abnormalities and outflow graft abnormalities can happen. They're much less likely to be a problem so early in the during the implantation time with the current pumps, but they can still happen, especially if the orientation of cannula, no matter how well they plan during the OR, people gain weight subsequently or lose weight or hematomas. It's a it's beyond what anatomic description that you would have seen prior to the implantation, that things can happen in that manner post-operatively, which would lead to a change in the orientation of the cannula, leading to some pump parameter abnormalities and flow issues. Pump malfunction and pump arrest is extremely rare. It's only you can't say that it's not going to happen. With current generation pumps, HeartMate 3, the pump failure itself is not a common thing to happen. So this is the Intermax data that we get. Every year the annual report comes out, and that annual report gives us an overall description of how many Intermax 1s or 2s, 3s, what Intermax profile went through the LVAD implantation, and outcomes by Intermax profiles. Essentially all sorts of outcomes will be reported. So one other thing I would want to highlight here is one of the early complications that happens. Number one complication post-operatively is bleeding, and that does happen. It's 20.7% here that's reported, but it usually ranges anywhere between 20 to 40% depending on the center. And hemostasis, as Dr. Prasad mentioned, is a key element in managing these patients. So rest of the things that you could see here are reported in different ways, but that's what I want to highlight. This is the way it gets reported in general. Pump thrombus has become really significantly low with the HeartMate 3 at this point of time. So device malfunction and pump thrombosis is not a major complication these days. Bleeding remains a significant complication, and thromboembolic events remain a significant complication. So this is the second one that is that we all pay attention to is the RV failure. There's so many definitions for RV failure because we have to input the data into Intermax, and typically it's elevated right atrial pressure with reduced urinary outputs and essentially if there is a prolonged need of inotropes for greater than 14, I don't know if it's written, yeah, it's written there, greater than 14 days, our need for RVAD is defined as post-operative RV failure. So again, the incidence widely varies between 20 to 50%. So elevated CVP, reduced pulmonary capillary wedge pressure, and echocardiogram is required to differentiate between RV failure and tamponade post-operatively. The severity of RV failure guides you like how to manage these patients. If someone has severe RV failure, don't waste time, go put the RVAD in sooner than later to facilitate reconditioning of the RV. If it is moderate RV dysfunction, I think aggressive volume management with CVPs have to come between 8 to 12, ideally 8 to 10, and inotropic support, inhaled vasodilators. So cost can become an issue here when you're using inhaled pulmonary vasodilators. Post-operatively, nitric oxide or epoprostenol could be used. Epoprostenol is kind of pennies compared to nitric oxide. So you would need to have a plan and contract with whoever is the supplier in bulk to minimize the cost for the institute. And there is no significant difference between the outcomes of using nitric oxide versus essentially epoprostenol. I think some surgeons prefer one way versus the other. Mild RV dysfunction, medical management. The thing is, the aggressiveness with which or more diligence with which you pay attention to RV can change the course of the patient significantly. So keep your ICU team essentially, take for them to keep eyes on this particular thing, and this is where the cardiologists play a significant role along with your intensive care colleagues to keep an eye on things to prevent RV failure. One should not identify RV failure late in the game. If someone's mixed venous sats are dropping, CVPs are rising, and urine output is going down, you should not be acting 6 to 8 hours after. So you should identify sooner, diurese the patient, whatever is required at that point of time based on clinical assessment that needs to be followed through. This is the pathophys. Again, we talked about it. It's the septal shift that causes actually causes loss of septal contribution to RV contraction can worsen pre-existing RV dysfunction and can drive it into RV failure, along with geometric distortion of the right ventricle and how the tricuspid valve is. Those things can affect. Essentially, this is the RV anatomy, which is RV is supposed to be a crescent-shaped chamber, and if RV becomes like a donut, that's not going to be helpful to cardiac output. Essentially, you lose any geometric distortion of the RV is not going to be helpful for RV function in general. That is the fundamental difference that I have heard from the surgeons, why they choose sometimes a thoracotomy approach over sternotomy approach. That's the breach of the pericardium leads to, kind of worsens the geometric distortion of the RV. If they have pre-existing RV dysfunction, a little bit like moderate RV dysfunction, again, they vary significantly from one person to other person. Some people preemptively put a temporary RVAD and go ahead with sternotomy, and some prefer whatever is the expertise that the center has and the support structure that center has. That's what is needed. That's what one should follow, essentially. So I think this would be repetition, as all of us have discussed. What are the parameters that would define or predict RV dysfunction, as we talked about. Essentially, higher CVP, these are all the metrics that are driven because of the higher CVP. Liver congestion, renal congestion, failure to, because of the renal congestion, it doesn't filter adequately, and then that leads to renal dysfunction, as well as your INR elevations. All of these things are suggestive of congestion. And echocardiograms can be used or should be used to assess the RV dysfunction. Again, this is another way of seeing this. If the RV looks like dilated, squishing the LV, that's not a good thing for either LVAD or the patient. And echocardiogram, all of these different things can be measured. Immediate post-op phase, there are few things that truly help with the windows that you have and all. TAPC can be helpful. RV fractional area change is what is actually really helpful, and LV-RV ratio, as well as some of the other things that you would have to measure tricuspid regurgitation in these patients, especially if the tricuspid valve was not addressed and there was more than moderate tricuspid regurgitation preoperatively. Although there is diverse data, some surgeons strongly believe in de Vega repair or whatever the repair that they choose to do of the tricuspid valve, and some surgeons don't believe at all. And based on the current data, there is no definitive answer should the tricuspid valve be repaired or not. There are some anatomic features, or some, if ICD lead is perforating the septal leaflet, that it might be worth repositioning it and repairing it. And if it is just a tricuspid regurgitation because of annular dilatation and LV is significantly dilated, unloading of the LV should recondition the RV, and that should be okay. So it depends, again, surgical colleagues' assessment and their judgment with reference to that. Obviously, we should give our input as cardiologists with reference to that. What are the red flags that you would notice post-operatively? So if patient had received a lot of blood products, that's a red flag, because that's going to strain the RV. And CVP greater than 14 is not a good thing for any RV, let alone post-operative RV. And mixed venous sat is dropping, and the drop is greater than 10%, and escalating doses of inotropes to maintain proper hemodynamics post-operatively, and sustained decrease in the urine output or low flow alarms. That doesn't mean that you have to immediately, at least you should pay attention and obtain additional information to make adequate judgment. If there is sustained arrhythmias, you need to know whether it's because the septum is pushing into the LV and the cannula is touching the septum, or it's because of any other thing, like something that's mechanically stimulating the arrhythmia. Is such a thing going on? That's something that needs to be assessed. Increased work of breathing, hypoxia, again, not good. If they don't have adequate lung, if preoperative lung assessment is not good or like borderline, those patients, if their ventilatory mechanics are not cooperating, that can, any higher PEEPs and all of those things can worsen the RV. So your ICU colleagues are crucial in the management of this vent to avoid acidosis. Once acidosis sets in, your pressors are not going to work, and you keep like escalating the pressor doses. That's actually correction of acid-base balance is very important for either pressors or inotropes to work. That means if the patient is not responding to higher dose of diuretics, start renal replacement therapy sooner. As acidosis worsen, none of the inotropes or pressors are going to work, and the acidotic environment, you'll have more death, myocyte, like essentially tissue hypoxia. That's not going to be a good, it's not a thriving environment for the patient at that point of time. So protocols for, in general, what has worked out well for patients that do well, or the institutions that do well, is essentially protocolizing it. That minimizes any type of care gaps. So as physicians, you can think and tease out the differences between one to other, but your frontline staff should know when to call you. Protocolizing things will help that kind of you, instead of knowing something 2 hours from now, you would know now. Like you would have to give clear instructions on when to call. So protocolization will help from that standpoint of view. Assess early, CVHD needs, volume optimization needs, as well as if the patient needs LVAD support. So this is an algorithm. So these type of algorithms, when you put and tape it onto your ICU, wherever the wall, that will help nurses or the ancillary staff or your residents, whoever is, your junior doctors, they would know what to do. At least they will come to you sooner by instituting what needs to be done. If someone's CVP is going up, then is it RV dysfunction or tamponade? If someone's CVP is low, what is it? What is going on? At the most likely bleeding. So look into that. So if someone's CVP is going up and they're in slow VT for a long time, call your EP colleagues fast. And if somebody is kind of like hypotensive and their CVP is low and they're having like uptrending WBC or having fevers, you would know that there is. But fevers can be tricky because if somebody is in low output state, they can have an inflammatory state, cytokine surge, and their fevers could be just from the inflammation rather than infection. So got to be careful. Not every fever is from infection. A lot of it is from low, basically low output state. So that needs to be assessed carefully. And one more thing that's very important is literally sometimes you require prolonged intubation just because patient is essentially, you're not able to minimize sedation, they're kind of fighting the vent or doing this. But longer you maintain the sedation, longer you maintain the vent support, that's going to lead to other problems. So you would have to have, again, protocolization of how to wean the vent and how to minimize the opioids or sedation is very important. Again, this is clear-cut depiction of how the hemodynamic shifts and what is the clinical condition that you're expecting, essentially. There is inflow obstructions and outflow obstructions are extremely rare, but if they do happen, they are essentially surgical intervention. There is nothing we could do. But tamponade sometimes, essentially our surgical colleagues, which when they say keep a little bit of transfusion, a little bit of time, can relieve, meaning because a lot of the post-operative time, they do have some fluids around, some like hematomas around that resolve with time. Not necessarily everything what you see as tamponade don't need to run to the OR. That's again multidisciplinary discussion. At the same time, you can't wait forever until the time they go into renal failure. Not taking them to OR is not going to help. And if it is a right atrial compression, it's not going to be, like, you don't want to waste your time there. Because regional tamponade can occur in these any post-operative patients, and they may not have typical tamponade features like you would see on the echocardiogram because of the breach of the pericardium. It doesn't have to be the classic features, because you can see sometimes it's just the right atrial compression. There is a clot sitting on the right atrium, so it's very crucial to know what your pathology is. If your RV is underfilled and there is right atrium is not seen, your CVP is going through the roof and your cardiac index is dropping, you can't say, like, I'm not seeing a fusion anywhere else, so I'm not going to take the patient to the OR. It's not going to work well there. Arrhythmias in post-operative phase. So if it is most LVAD patients can tolerate arrhythmias because their VTs are tolerated well, because the primary reason why VT, you need to shock and all of these things is your cardiac output is affected, and when you don't have adequate cardiac output, your tissue is not getting oxygenated and you're going to die with cerebral anoxia, or like essentially tissue hypoperfusion. That's the defining or like the spiraling down to death. That's the reason why the early interventions, shocks, all of those things are essential in regular patients. If you and I go to VT, that's what is required. But in an LVAD patient, no matter how much of VT they're in, pump is unloading. So there is cardiac output that is, or pump output that's there and perfusing the body. But what it will affect is your VT is not happening selectively to LV. It's happening to both RV and LV. It will be it will come to a point where your RV is going to be affected and RV failure is going to occur. So that's the reason why if they have borderline RV dysfunction, you don't want to keep them in the VT for a longer period of time. So you would want to intervene sooner. And atrial fibrillation, again, is well tolerated, but you don't want to take risk in a patient who you have patched the aortic valve and the whole output is pump-dependent output. So the loss of atrial kick might affect in that patient. In a post-operative patient, some patients, if it is hemodynamically significant, address it. And at the same time, if it is not hemodynamically significant and the rates are 110, 100, and patient is doing fine, there is no need to rush and do something about it. So it's a clinical judgment. And one of the important things to know is this a mechanical problem? Because if you're running at high speeds and your cannula is touching the septum, and that's why that's what is driving your VT, reducing the speed is the right thing. There is I guess we can call our EP colleagues and they'll tell you, why don't you get an echo before you call me, would be the answer that one would get. So arrhythmias, when they happen, fluid boluses, antiarrhythmic agent, normalization of serum electrolytes, it would really be not a good thing to call your EP colleague and your serum potassium is like 2.4. So while you're diuresing the patient. So just look into the basic stuff before we call. And post-operative use of beta blockers is a little bit of frowned upon, especially if there is RV dysfunction, so you got to be careful. You could use a little bit of DIG in the cases of atrial fibrillation. Again, you have to look into your renal function. Amiodarone and mixolydian. Mixolydian is like, you're treating yourself sometimes, but it does help in some patients post-operatively. But in chronic maintenance phase, it does work. But we use amiodarone mostly and Lido in some cases because the indication sometimes for patients that although it's not favored, if there is recurrent persistent VT and patient is not a transplant candidate, young patient, although that's technically not be supposedly not going for VAD, we do that. So for those patients, sometimes we have to use lidocaine and profound antiarrhythmic agents at some point of time, defibrillation, and actually for these patients, they can change the ATP settings to a much different level to even avoid, to give recurrent rounds of ATP, and that actually works in some patients. So actually, some patients, like some electrophysiologists, use dilantin. That's a medication that's used in VAD population. There are some people that strongly believe in it. There are some people that do not believe in it at all. But there is a place for that depending on who you consult. So the arrhythmias. So there is always a conversation on what to do with the devices in these patients. Meaning, if somebody has a BIV, should you maintain BIV pacing once you have an LVAD? Because technically, if there are smaller LVEDD patients, it may be best to turn off the LV lead. Because the whole idea of CRT is you're contracting and pumping more blood. Once you're sucking the blood out, there more contraction can lead to smaller cavity. So there is a AHA statement, but at the same time, if you have a lot of AI or the MR, it may be best to leave the BIV pacing. And if there is RV dysfunction, a little bit of RV pacing might be helpful to maintain at 90 to 110 in some patients. But that's, again, you have to do echocardiogram to know whether that is feasible or helpful or not. So there is a little bit of a tricky thing. Even generator change at times is recommended, not recommended. If somebody never had VT in their life, should you change the generator on somebody who has a VAD? Probably not. It's okay. But if it is an ischemic cardiomyopathy patient who had VT episodes in the past, it's worth changing. And again, sometimes there is frequency interference between the devices, and if the patient ICD is not working because the frequency interference between the LVAD and the ICD, changing the battery is not going to be helpful other than subjecting the procedure for another procedure. So those are the intricacies that you would pay attention to. Again, this is a pictorial depiction of the same thing that we saw in the previous algorithms, just different ways of projecting depending on who is looking at it and how they would want to understand it. So physical therapy and rehabilitation is a crucial part of recovery. Sterile precautions are important. You don't want sterile dehiscence and do not want to have those complications and subsequent surgeries. So it's very important to follow the sterile precautions. And basically, they have to be taught well how to avoid trauma to the driveline. Especially right after the surgery, it's still not incorporated, it's not scarred out, it's easily mobile, and you will have ascending infection. And the current pumps are pericardial pumps, unlike HeartMate 2, which is a preperitoneal pump. You have a different pocket. If there is infection, the way you could actually do the pump exchange with a subcostal incision without having to do the sternotomy, but that's not the case with either HeartWare or HeartMate 3 because they're clip-on devices to the heart. If there is ascending infection, your pump is going to get infected. So preventing the driveline trauma is the number one priority for these patients, so that like that tug, pulling, pushing should be avoided post-operatively. And I mean, hopefully they don't soak them in water when they're in the hospital, but when they go home as well, that's something that should be avoided. So it's important to educate the patients about the care of the driveline and in general care of themselves in post-surgery. So there is clear-cut evidence that loss of pulsatility leads to some cognitive dysfunction and their exercise physiology changes, so they need cognitive retraining. I think a lot of times they develop hand weakness because of the neuropathy post-surgically, so those are not strokes, but they have neuropathy post-operatively, so they need therapy for the improvement of their weakness and the coordination. Caregiver and family education is very crucial, and in general, to prevent debilitation and loss of muscle mass, they need rehabilitation. Patient education is key, and they need to know how to handle the equipment. They do have psychologically, I think no matter how we say it, how clearly, I think sometimes people hear what they want to hear. All they hear is they're going to do better, and they do not want to like they would ask like really strange questions post-operatively. You're like, I think I discussed this with you in detail. I'm not sure what happened. How did you expect to run after the, any kind of cardiac surgery? You just, I don't know. I think sometimes people expect medicine to be like turn on, turn off, like you turn on the switch light. That's not how medicine works. There is kind of a lot of ifs and buts. It's hard to process, especially my husband is an engineer, but I can tell you still engineering people, they think it's like this is how they're the hardest patients to manage. They're either very cooperative or they're very it's not a logistical algorithm that works that way in medicine, so some reason they cannot comprehend it. So sometimes over-education and online searching is not very helpful. This is again Intermax data. I don't think I need to show this. I just had some pretty slides that I put it in. So that's that talk, and that gives a segue to go to our next topic, chronic management of LVAD. So that is immediate post-surgical management is a little bit different than chronic management of the LVAD. So initially, it the whole actually the research in mechanical circulatory support preceded the heart. National Blood Institute funded it, but then it miserably failed, and then they took a break and then went with the left ventricular assist device. Initially, a lot of investment was into total artificial heart. So that's the gift of human heart. Now you know how newspaper headlines change. Then Lisa waits for a heart and dies, and then heart, basically as if doctors have hearts growing somewhere. I mean, I understand that's a sad thing to do. Then there is man makes a heart. Then the security for people like me as in heart failure cardiologist came through REMATCH clinical trial. Before that, basically heart failure cardiologists were not as valued in the United States. We were essentially doing it out of passion rather than anything else. We still do it out of passion, but that gave kind of essentially the societal uplift to what we do. The mortality has significantly, actually survival has significantly improved, mortality is significantly reduced. Now, the early outcomes of LVAD are comparable to transplant. Although you have slightly higher mortality with LVAD, imagine, or at least think about the fact that people who went to LVAD sometimes are not candidates for transplant, and they're more, advanced age, more comorbidities. They have some risk factors that prevented them to go through a transplant, and significant patient population that's undergoing transplant or LVAD at this point of time is kind of destination advanced age population. So given that burden, you still have very comparable survival. So that speaks volumes at this point of time. So again, so from it could be done as like a bridge to transplant to the late, it's not even latest, 2015 Donna Mancini's publication, Rapidly Evolving Alternate to Transplant. That's how LVAD is viewed currently. It's no longer destination or bridge to transplant, more like short-term use versus long-term use. As Dr. Nitin already mentioned, if drug use or the smoking was the reason why they couldn't go for transplant, that indication changes if they refrain from smoking and drug use and reform themselves. So those are very interchangeable. Some people might potentially be bridged to transplant. If they suffer some stroke and all, they become destination therapy. They're very interchangeable at this point of time, so it depends on, well, this is all historical data, how long ago the LVAD came through, and the DeBakey's, and so this is like all older generation VADs, which Dr. Prasad already went through. No need to repeat. These are clinical ranges. These are not operational range that's given by the device companies. Actually, HeartMate 3 can be operated even at 4,900 and 4,800 in some patients. But these are the average clinical ranges that you see in most patients. So one of the things with these pumps is loss of pulsatility. So your physiologic circulation is pulsatile flow. Because of the pulsatile flow, you don't form your vascular bed is not subjected to continuous pressure, right? Now that you have continuous flow, that variability is gone. So your vascular bed is kind of a little bit more rich with blood to a degree where there is AV malformations that are formed. And some people are more prone to it versus the other people. How is it relevant to you? Because there is mucosal bleed and non-mucosal bleed in these patients. Like when somebody GI bleeds, it's not always because they have AV malformations. Sometimes it's just mucosal fluffing and diffuse mucosal bleed where you cannot find any focal bleeding point. So non-mucosal, the mucosal bleeds are mostly because of essentially loss of pulsatility. People will have epistaxis or GI bleeds that needs to be considered in these patients. So they become a little bit annoying. Obviously, you would have to change the anticoagulation goals. Sometimes platelet function testing would be very helpful, such as TEGs, to adjust the anticoagulation. There are some times where we have to completely withdraw Coumadin and leave them on aspirin. Like we have to alter their anticoagulant and antithrombotic regimen. So most of us feel comfortable with HeartMate 3 to withdraw without a lot of pump thrombosis has significantly gone down with HeartMate 3. So we do feel comfortable if we have to in these patients. So you would have to look into, in the care of LVAD patients, physician and care team is part of the care. And you can't run to like your, care provider team that like everything is like their burden type of a thing. There is responsibility for patient and family. There is responsibility on the institute to prepare for this, and they have to be like process mapped. Care pathways have to be delineated. Policies and protocols have to be delineated. Ancillary staff has to be given to actually improve. I mean, there has to be a quality process to have good outcomes in these patients. So routine care of LVAD patients should involve education. Education should start from the evaluation process itself, but they should have enough understanding prior to discharge. Notification to look, I don't know how this works here because for our patients, we notify local fire stations because if they get into any trouble, they will be brought to like LVAD facilities or closest ER and shipped to LVAD facilities rather than just living at a place where they don't know what LVAD is. And we notify electric companies so that they don't cut off the power line even if they don't pay the bill. Please don't, because it's a life-saving device. And in terms of storms and all, they are the first people to be evacuated because they don't want to stay in like, if there is a flood or, so the fire stations will be kind of like notified, these are the LVAD patients, and that's a routine process now. Patients should know equipment handling because they can be tugging things, pulling things, and kind of tipping over and like falling. That's not going to be helpful to them. So they need to be taught how to handle the equipment. So recognition of alarms is something that they need to know, and for them to document daily what their LVAD parameters are, that's very important. And it's just like give a sheet, prepare a sheet just so that they document and know the trends. Monitor blood pressure and vital signs at home. We ask them to, some people can get Dopplers, their insurance approves, and some people can get blood pressure cuffs because HeartMate 3 does have some pulsatility, so we do ask them to get blood pressure cuffs if they can, to monitor. Sometimes it succeeds, sometimes it does. At least the trend will be helpful to you. Like cross-sectional data might not be helpful, trend might be helpful. monitoring INR, home INR machines, and care of driveline exit site is very, very important. The frequency of the change, like, if you want to pour water every other minute, that's not going to work out. So it's basically education. Who is the point of contact from the facility? That's one place where institute has to be willing to spend a nurse coordinator, even if it is a shared FTE, because in cases of like any questions, emergencies, they need to have a point of contact, and that can be a heart failure cardiologist 24/7. So you would need to have an arrangement. We do have VAD coordinators. There are angels, guardian angels, but somebody should be there for them to reach out, because not every call requires a hospitalization. That just requires a little bit of reassurance. Sometimes they need engineering help, so that needs to be a little bit requires planning from the institute standpoint of view. So you should always remember, why did we implant the LVAD? Because to facilitate the forward flow, right? And if somebody is having AI, they have flow through the pump that's not necessarily going to the body. So that's a complication that would interfere with the care of the patient. And you would have, the other thing that's very important with any pump is the interface between blood and the pump. So that leads to, like, that what we call hemocompatibility. That's what leads to a lot of complications, because this is a mechanical surface. Your blood is going through mechanical surface. Obviously, there is going to be lysis of the cells. And when there is lysis of the cells, they're going to be more adherent to when the RBC gets lysed off, free hemoglobin is floating, and platelets get chopped off. That's going to be sticking to the device, and nidus for thrombus will be initiated. So thromboembol, anything that has external to internal contact will have infections and propensity for ascending infections. And we need to pay attention to their disease process, like the myopathy, whether they have ischemic, non-ischemic cardiomyopathy. That will play into management few different ways. Because if somebody has RCA disease that was not revascularized, somehow they, post-operatively they struggle through, still late RV failure is a possibility if not adequately managed. And even early RV failure is a possibility. Sometimes, if it's a CTO, there can be a bypass that can be done for right-sided lesions to prevent RV failure. At the same time, you have to weigh the risk versus benefits, length of your CPP time versus the benefit that you're going to get out of that. So the primary process need to have some attention to be paid to, because if it is a burnt-out sarcoid patient that you implanted, they're still going to have VT, so that needs to be paid attention to. Driveline, how the driveline should be dressed, should be taught. So especially for HeartMate 3, there is a modular portion, so it needs to be anchored above and below the modular portion. So, and avoid any kinks. Dressing has to be secure. Anchoring, until the time it's incorporated, it has to be dealt very carefully. The scar formation around the driveline exit site is crucial. Again, this is the way it should not be done. Look at the way that these are like don'ts. Essentially, there is an anchor and your driveline is outside of the anchor. Like this happened, and that's not going to be helpful to the patient. If you're anchoring it to the leg, that's not going to be helpful. It has to be on the abdominal region. When they walk and it's anchored to the leg, it's going to pull out. So please, I think this is one thing we need to educate nursing staff. Sometimes for the convenience or because they want to wash certain regions, they change all of these things, but there is consequence to such change. Whatever the way you want to document, but prepare a form, and it should be part of medical chart and daily assessment. A physician doesn't have to fill it. Any nurse or nurse practitioner, physician assistant can fill it, but there has to be a documentation of it to know whether something has changed or not changed. Measurement of blood pressure is a key thing, as we discussed. Hypertension can lead to low pump flows, and that's not going to be helpful to the patient. And truly, for centrifugal pumps, there can be retrograde flow. So appropriate management of hypertension in these patients is essential. So these are anticoagulated patients. If they're hypertensive, they can bleed into the brain, and that's not the outcome that either the patient or the care team wants. So ISHLT guidelines define how to, you have to maintain the speed to a degree where you adequately unload the LV, but at the same time not pull the septum to the left side. And the preferring agents for antihypertensive management is essentially heart failure management, like how you manage the agents that you use, neurohormonal blockade agents. Part of the reason is that facilitates recovery, if they have potential for recovery, and also these are proven agents, and they do have underlying myopathic process, which should be addressed. So how do you want to follow up with these patients? Again, a protocol, whatever it may be. What is the frequency at which you want to draw which lab, and when do you want to get echocardiograms? All of these things have to be mapped out. This is Jerry Estep's article, and this is what he came up, or they published. But one doesn't have to follow this, but whatever the frequency that institute wants to do, that needs to be followed. Again, LVAD complications. Essentially, these are the things: patient-related ones, healthcare system-related ones, and some are management-related ones, and pump and the blood interface. Those are the ones that define the complication. If somebody is going to be non-compliant, no matter what you do, it's not going to be helpful. That's an attention that one should pay during the selection process. If they're not going to have financial support subsequent to the implantation, it's just waste. Especially for a country like India where they're putting out of their pocket, it's just basically they're wasting huge amount of resources up front without plan for subsequent care. So that needs to be discussed, that they should be prepared for subsequent care as well. Social support is very essential because somebody needs to change the dressing, somebody needs to take care of the patient. They should be able to accept the worst case scenario and should be willing to proceed for these type of therapies, because nobody knows who gets a stroke. Sometimes the whole family disappears and we have a patient with stroke sitting in the hospital forever, and that's not like a complaint, but essentially it becomes very difficult and challenges in management. So this is primarily because, to show, this is the HeartMate 2, and then this is HeartMate 3, and what it is, the difference between these two pumps, essentially from our standpoint of view, cardiology standpoint of view, is, so as an axial flow pump, you see the rotor, right, and the motor, the amount of blood contact that's going to basically interface with the mechanical surface and blood is larger in HeartMate 2 versus HeartMate 3. HeartMate 3, the stream is a little bit thicker, so it's usually like the periphery that's going to come in contact. So for the centrifugal pumps, you're entering and propelling and exiting at 90-degree angle versus axial flow, which is propelling in a point of entry and point of exit are at 180 degrees essentially. So because of that, you're going to have more lysis. That means what are normal LDH in a HeartMate 2 is different from what is a normal LDH for a HeartMate 3 patients. Like HeartMate 3 patients, you would see LDH, baseline LDH in 200 to like maybe 300, 400 range, whereas HeartMate 2 patients, you see 400 to like 600 range. Usually they're mostly run in 400s, and for this it will run in kind of a little bit less. Assessment of a patient with LVAD, just assess the patient just as any other patient, check the connections. You can defibrillate the patient if required, can do chest compressions. If the pump is not, essentially, if the pump is not working, there is no LVAD hum, you could do the chest compressions. But get the vital signs, look into the alarm history, and neuro examination, driveline exit site assessment are the key. Clinical presentation, you can have mechanical dysfunction, extremely rare. Anticoagulation is kind of, then they're prone to bleeding, and if your maintain INR is low, you're prone to pump thrombosis. atrial fibrillation, obviously ventricular arrhythmias, RV failure, renal failure. These are the potential complications. There are no surprises there, but can a LVAD patient come with heart failure? Yes, they can have RV failure. They can also have, if you're not unloading adequately, they can still have like kind of LV failure. And the TR can lead to RV failure, so those are the things to look into. If patient has pre-existing pulmonary hypertension, that can strain the RV as well. Those are the things to look into. Pump malfunction is extremely rare, but most likely it's the lack of power supply at that point of time. At some point of time, pump thrombosis happened because of people took the liberty. They were having like neurologic events or like essentially intracranial bleeds. They scaled back on the anticoagulation post-operatively. That led to pump thrombosis, and this is the Sentinel publication that came with increased pump thrombosis. Good thing about that is that led to basically intense work on generating another pump, that's HeartMate 3, but which is a good, better pump from that standpoint of view. Otherwise, as long as some pump works and you're marketing well, people don't invest in like next generation technology that much. So there is a fibrin-rich thrombus and thrombin-rich thrombus. Essentially what it means is your ingested thrombus, like as you can see, which can happen with HeartMate 3 very well, even the myocardial piece that you're talking about, that will lead to ingested thrombus or ingested foreign body can give central neurologic sequelae. That's a little bit different than lysis-related, and that's like a fibrin-rich thrombus. You start sticking over a period of time. You can have non-occlusive thrombus and then propagate to occlusive thrombus. And CT is actually you can do ramp echo, but CT is the preferred method to look into pump thrombosis these days. This is the algorithm that's published essentially in JHLT, and that's pretty much all institutes follow this algorithm at this point of time, and it's tailored to the patient needs and other clinical scenarios that one would encounter. But this is a fairly kind of standard algorithm that most institutes follow. So you need to look into whether there are signs of heart failure. If a patient comes, is there a pulse? So this is the tricky part. These patients should not, I've had a medical student that said, like, patient has good pulse. That's not a good thing, because that means the pump is clotted. Like somebody, at least the aortic valve is opening. A patient who should not have a pulse is having a pulse, meaning that there is significant flow through the aortic valve. And why should we check pulse? Some of the medical students or the residents and the fellows ask that. So that's the reason why even if they have VAD, you check the pulse to, if you feel the pulse, that's not a good thing essentially. And you do the basic workup, echocardiograms, INR, LDH, T-colored urine. We have to educate the patient. Change in urine color is something that we need to know. They need to let us know. And sometimes it may be just simple UTI, or it may be true hemolytic urine. And plasma-free hemoglobin can be measured at times, but RAMP study is very important. Pump thrombosis. Infection can work both ways, especially if you have pseudomonal infections. They lead to intracranial hemorrhage eventually. But a lot of infections can lead to prothrombotic state, and they kind of work as, pump thrombosis can happen. Aortic insufficiency on a long run can lead to pump thrombosis because there is a lot of shear stress and lysis, and hence like a sticking of the cells. GI bleeding. The way GI bleeding can, you can say bleeding and thrombosis are the opposite end of the spectrum. How can they both happen at the same time? It's the withdrawal of anticoagulation that might precipitate it. It's not so much common in HeartMate 3, but it can still happen. As I said, that HeartMate 2, you could have subcostal pump replacement without having to do full sternotomy, but that's not the case with current generation pumps, as they're pericardial pumps, and you would have to essentially breach this chest space to get to the pump. So your presentation can range from asymptomatic to cardiogenic shock with pump thrombosis, depending on the degree of thrombosis in these patients. Again, thrombus initiation, if it is thrombin-rich or fibrin-rich thrombus, this is how it will propagate. Cerebrovascular events, again, both ischemic and hemorrhagic events are probable. Infection, pump thrombosis can lead to this. Hypertension can lead to this. So adequate neurology and neurosurgery, one would need to have some coordination with neurology and neurosurgery. Most neurosurgeons don't take these patients to the surgery because of continuous flow physiology and anticoagulated state. But we have sent patients and they've all remarkable recoveries. Driveline exit site infection, it can be of different degrees. So early intervention, antibiotic treatments, and when required, surgical interventions are very essential in these patients. So these various ways that I think patients need to be educated on how to manage their driveline exit site, and sometimes you have to do the retunneling. And that is kind of like if you have deep driveline infection, you don't want more ascending infection, so you can retunnel the driveline. So you have to differentiate between VAD-related infections and non-VAD-related infections. VAD-related infections can range from superficial driveline infections to like at exit site to pump pocket infections, mediastinitis, and VAD endocarditis. So when you have pump endocarditis, it's like lifelong antibiotics or to the transplant. So it's important to prevent that. And non-VAD-related infections have to be treated aggressively so that they don't become systemic infections and seed the device. So pneumonias, UTIs, pancreatitis, any bacterial infection should be treated aggressively. This is a great document to review for how to treat essentially any mechanical circulatory support devices, how to treat infection. ISHLT has like a lot of consensus documents. Again, these are not going to be evidence-based STEMI type of documents, but there are consensus documents that are present. Again, there are important ones to pay attention to is aortic insufficiency and tricuspid insufficiency in valvular heart disease, from valvular heart disease standpoint of view in LVAD patients. How your aortic valve should, in series or parallel, is fundamentally what happens when you put an LVAD in. And if you have it backward flow, you're not contributing to the forward flow. So your pump parameters will look great. Your flows can be 4 and 5, but it's not perfusing the body. It's just leaking back into the pump. So that's not going to be helpful. This is an extreme case of a patient that we took care of. The regurgitant jet was such that it was essentially entrapment into cannula. So that is not a good thing for this patient. But there are several ways to address this these days. I'm sure interventional colleagues would be super excited. Back in the days, there was essentially they were switching to bioprosthetic valves, but patients can be non-operable candidates. So TAVRs, ampulas, occlusion devices. There's several ways to approach percutaneously at this point of time. I think a lot of times AI can be underestimated preoperatively. That's the reason why AI should be assessed intraoperatively, because if your LVADP is high, your assessment of valvular regurgitation is going to be low. And once adequately, like in intraoperatively, when LV is unloaded, the AI can pop up at that point of time. So intraoperatively, that needs to be assessed. These are like a little bit extreme things. Again, this is a feast for interventional cardiologists, like how the outflow graft occlusions, they're like stenting, like retroaortic approach and stenting. So there are many ways. Over a period of time when you do a lot, some of the interventions you're forced to do because they're not surgically like repairable because of patients' risk factors, comorbidities. So innovation comes through necessity. So that's what I guess like medicine will progress that way. And continuous flow LVADs are preload dependent. If nothing else, preload dependent, EKG independent, afterload sensitive, need to be anticoagulated. Any mechanical surface and blood interaction need to be like mechanical valves. The way you can extrapolate the data for VADs is from mechanical mitral valve data more than anything else. technically you can say mechanical aortic valve, but that's not the case just because of the velocity of the flow is a little bit different, and you want to be more safe. Mechanical mitral valve data is kind of like what we extrapolate. For example, we had to do LVAD in a patient with sickle cell trait, so we extrapolated the data from mechanical mitral valve to see where, how we could approach. They're prone to infection, bleeding, thrombosis, and mechanical malfunction, although extremely rare, and they're essentially the risk factors that we reviewed. What are the things to expect with different ways of presentation? We went over it. Can you do anything? Yeah, you could do a lot of things. We did implant, like, 2 hardware devices as a BIVAD, and there is another patient that was essentially cannulated multiple different ways, as you can see. You could do multiple things, but should you do it, or do you want to do it? That's something that one needs to think about. Chronic LVAD therapy does bring changes because you see the MMPs going down, the renin-angiotensin axis, like essentially improvement, and improvement in myocyte function is something that you see. This is, I think I'll skip, but one could review this. There is a 5-year outcome data from Momentum that was published recently. Very fascinating data. As you can see, the suspected pump thrombosis is way, way, way less between HeartMate 3 and HeartMate 2. And I guess we always have to balance these things: survival, adverse events, and quality of life. If somebody is surviving with a debilitating stroke, that's probably not, a great outcome, but sometimes we can't anticipate. I think all we could do is give risk versus benefit ratio and tell, like, we can anticipate who will experience and these are just some of the great papers, if anybody wants to review. These are like, this is the best document currently, like for EATS, like they have like a review of long-term durable mechanical circulatory support device type of thing. So, and these are all great papers anyway. So, hopefully, I'm not too late. Okay.
Comprehensive talk, and I know you had a lot of ground to cover, so you did, I think, but you did give a very good overview of most of the things which we can encounter. So maybe we have a couple of minutes for some discussion. So being biased as an electrophysiologist, I'll start with the arrhythmia issue. So if I understand, AF and VT are probably the two main concerns. So in terms of treating VT, how aggressive do we get? If I understand right, your main concern would be the RV dysfunction if it's causing low pump flow. So at what point of time have you seen your the EP people there, deciding I need to take an ablate, or versus I can tolerate some slow VT? How do we decide?
So very seldom do you need to take post-operative VAD patient to the EP lab, meaning this is mostly some mechanical things, and most of the time they settle down over a period of time. You have to pass few hours and they settle down. It's more the patients with recurrent VT and progressive RV failure because of it. Immediately, just because of VT that's like running even 120, 140 is not going to affect these patients right away. These are the only patients that you see, they're in VT for 2 to 3 days and still clinically stable type of a thing. But at some point of time, especially if they're waiting for transplant and they're having recurrent persistent VT, at least it's worth trying. It's not immediate. It's usually, if it is recurrent and persistent and you exhausted all medical management options.
And do we have any specific precautions in terms of doing the DC cardioversion or defibrillation in these patients? And have you encountered situations where it has affected the pump in any way?
So we didn't have any experience with defibrillation causing some major events in these patients. I think I have heard from, this is not even an event like that they had to put a pot because the defibrillator was not interfering with essentially the frequencies of the VAD and the ICDs can interface. So you use external defibrillation, essentially you inactivate the ICD and put external defibrillation. pads and externally defibrillate. That has happened a few times, but not. It doesn't affect. It doesn't affect with what we do in terms of external defibrillation. If they hemodynamically they warrant defibrillation, we should defibrillate. If hemodynamically not affecting, waiting for EP colleagues to change ADP settings would be better.
And one last quick question as to the CRT, which you mentioned that you decide, and in your experience, how often has the LV lead been left on versus off?
So, in our experience, depending on the center that I worked at, it's also like that. I would turn off LV lead if their cavity size is less than 6.2 centimeters, because there is no point of IV pacing at that point of time. At that point of time, you're causing smaller ventricle propensity for, essentially VT, and leave essentially, turn off the LV lead is what we do. The only time we leave a IV pacing is when there is MR, or when there is inadequate LV unloading and you can't crank up the speed because of their arrhythmias or some other clinical, like you want to wash the aortic valve. So that time IV still has, you still have value. And if there is MR, AI, these are the things that would make me keep the IV.
Thank you. It was such a wonderful, comprehensive discussion. We can't help but say that it's replacing one disease with the other. You did mention a list of complications, but we would like to know what are the common dilemmas you had to face. Apart from the surgeon and intensivist bickering over the re-exploration, what are the common dilemmas you generally face?
So the dilemmas are essentially the clinical course-wise. People expect miracles. It's truly the trading of risks, different risks that come with prolonged life, and they succumb to other complications, such as, let's say, somebody falls and they now develop a huge hematoma around the hip, and you have to stop the anticoagulation. Then there is tug of war that goes between orthopedics and you, like how long it needs to be stopped. So everything on LVAD patients will be ruled by the LVAD team, essentially. So every subspecialty that comes into play, you will go through this until the time system matures. This tension or like this space, like where like GI team comes, like, oh, this patient doesn't need scope. That I'm like, no, this is a VAD patient. It's a different patient. Like, we need scope. So those until the time system matures to know what to do with the patient, that kind of can lead to a little bit of the best thing is to prepare the system. Just have a meeting with the most common people that you would have to interact with is GI. So sit with the GI group and say that, hey, these patients are not normal patients. When this patient comes with a bleed, the patient would need EGD and colonoscopy. If you did EGD colonoscopy a month ago, you would still have to do it again. And those type of scenarios, it's better to have that conversation beforehand with the teams when you start the program, so what to expect. Then you would have, similarly, nephrology is the another team, because they like to keep kidneys a little bit wet compared to it's like a tug of war between nephrology and cardiology. So you would have to figure out either a person that can work with the team or like a group that can work with your team, not having to go to in the middle of the night when a patient's CVPs are raising and you want CVHD to be done. You don't want to be arguing with someone with what needs to be done. It's like sometimes you have to talk to a fellow, and fellow is giving you a lecture on how to whether to do it or not. It's like something that can happen. Then I would have to say, hey, I'm heart failure cardiologist, just get your attending and start doing CVHD type of thing. So those type of interactions can in the maturing system. But once it's matured, they come to a point that RAD team, they'll probably consult you behind your back, but they'll do what you want to do after a while. So.
And just extrapolating from the transplant scenarios, is there a discussion in your team about, is this patient having an obvious RV dysfunction, or are we sitting on an RV dysfunction and do we need to do something? Is there a dilemma on that?
So yes, that is actually one of the most challenging things that happen, because a lot of the times, you don't want to subject somebody to RVAD too early, but at the same time, you don't want to play catch-22. So that has to be multidisciplinary discussion. Like your CT surgeon, ICU, and cardiology at the minimum is required. Sometimes nephrologist in terms of volume optimization. That is always, you don't want to do too much. You also don't want to do too little. So it has to be a multidisciplinary discussion. Then it becomes like you could jump either way. So what you need is close monitoring. So your ICU team becomes the pillar of support to communicate with CT surgeon and cardiology to see at what point whether the patient is improving or declining. So it needs close monitoring to make the decision whether to make the decision whether to run back to the OR versus see, if you start dialyzing, take the volume off, and your lactic acid starts getting better and your inotrope requirement goes down, that is a different scenario than if you started removing the volume, but still lactic acid is uptrending and mixed venous sat is not improving. That's a different scenario. So I think close monitor, if there is a kind of a you don't have clear-cut answer yet, like you don't know whether it's a sunrise or sunset yet, the time only can tell. So close monitoring is the path that you would take at that point in time.
Just one last question from my side. How long do you keep invasive monitoring for cardiac output, for right heart?
It depends. There are some patients we removed within 48 hours. There are some patients that require longer. If we anticipate RV failure, we leave chest open for 24 to 48 hours sometimes, so that RV can recalibrate and accommodate and optimize. So in those cases, it will stay a little bit longer after the chest closure. Again, you would want to make sure that the RV is not getting strained at all. So it depends on how the patient is doing. Try to D-line as soon as possible and as best as you can, but sometimes it's inevitable.
Thank you, madam. Very nice talk actually, and very educative. I just wanted to ask, inflow malposition, if is occurring, especially after the thing has started, what is the incidence like and how do you correct it? Besides, of course, flow reduction or whatever, but is there any surgical merits we have to do?
So there are very few cases that go back to the OR because of inflow malposition. Immediate post-op period, it's unlikely unless there is a pericardial hematoma or something that's abutting the inflow cannula that needs to go to the OR. The reason is this will change eventually, meaning sometimes they lose body mass, sometimes they gain body mass after the discharge over a period of time. That will change the orientation of the cannula. Most of the time you want to address with, as long as they're hemodynamically acceptable, with the speed optimization and the patients will learn quickly, when I lay this side, it just makes me feel a little bit lightheaded or dizzy, and you can see changes in the pump parameters. Even in the clinic, you will ask them to hey, lay down onto the right, lay down onto the left if it changes the pump parameters like the flows, or if it triggers a slight NSVT, those things will help you delineate a little bit. CT scan can help you delineate, but it's extremely rare in the immediate post-operative period when it is so dynamic to change, taking them back to OR for the inflow cannula orientation. But you try to take your precautions to avoid certain positions. And if there are pleural effusions, pericardial effusions, that's what is causing you, address them appropriately to ensure that that component is taken out.
Secondly, is it MRI compatible for any other problems?
No, once you have VAD in, the MRI is out of the picture.
Because in one of the X-rays, the inflow looked as if it's a bit towards the
it's a lot of malpositions, they live that way without significant clinical events. So every it's like every kind of not so perfect alignment does not require clinical intervention. Like sometimes it's like time and a little bit of readjustment. Like if somebody has gained like 50 pounds after LVAD, especially on the chronic therapy, asking them to lose weight may be a better approach than to go for surgery. So,
due to time constraints, we'll move on ahead. We have one more talk.
Anyway, that next topic was regarding the current status of LVAD as a destination therapy, but already we have shown the momentum 3 trials, even 5 years extended data. So that is not required. And then we have a healthy discussion regarding this, whatever the panel discussion we planned. We had a healthy discussion. I think there is no need of
okay,
sessions.
I agree.
Everything is covered almost.
I agree.
I have one question. So for a small BSA patient, so usually they require low rates, low RPM. So then we have one, that patient had a frequent low flow alarms whenever she had a persistent cough and those things. And how to deal with them?
So this is a very important question. A small BSA doesn't necessarily mean small LV. There is some people it correlates, some people it doesn't. This person seems to have smaller LV cavity based on what. I think this patient, you may have to run a little bit lower RPMs. I think the low flows, you would have to do the ramp echo to see what happens at different speeds to the LVAD parameters, and based on that, you pick what is the right speed. Because the low flow can be because essentially you're not adequately unloading the LV, or it's such a small cavity that you're abutting so whatever it is that you would have to figure it out with the ramp echo. That would be the strategy that I would choose.
So for our patient, just a change of 100 RPM, so then low flow alarms has come down.
I think very small changes can lead to, if she is such a small person, even 0.5 liters might make a huge difference to her. Because what you need is a plump LV, little bit plump LV. And let's say your cannula is perfectly aligned. It doesn't have anything to do with the cannula, how the septum is. Like if you are 4.5 LV, you're still going to touch. So that's why, like, if you give little bit extra kind of like plump LV, then you don't touch the wall. And that is what is, you probably are encountering sucking events. That's what it looks like. They look like suck events to me. So, and if your speed is dropping with each of those, so there is a baseline speed and there is a backup speed, right? The backup speed is essentially a safety mechanism when your cannula touches the septum to prevent the suck events and persistent VT. We didn't talk about it, but that's a suck event when you have smaller LV cavity. So it's inherently built to fall down to that speed so that to allow LV to fill and prevent the further suck events. So I think going down on the RPMs would help, but without knowing, like, if the patient has AI, that's a different thing. So doing echocardiogram would be very helpful. If there is a lot of TR, you would want to manage it a little bit more differently. Because I also saw your patient was on sildenafil, if I remember it, like ongoing sildenafil use. Okay, so how much of?
Last 1 month back only stopped.
Oh, okay. So the RV is okay, doing okay. Okay. In that case, this looks like underfilled. Basically the LV that's being a small LV cavity. That seems to be the issue. So reducing the speed should be sufficient.
Dr. Mridula, you did mention about the ERAS being one of the strategies for your post-operative care. ERAS.
Oh, yes.
Yeah, ERAS protocol has now become pretty much the standard of care for most of the GI surgeries. One, do you go for regional pain management with either an epidural or not? That's one thing. And second, how many of your patients actually go through nutritional rehabilitation prior to the placement of the VAD, and are they put on any nutritional supplements?
Okay, so in terms of ERA, actually this came from non-cardiac surgery, extended to cardiac surgery, now extended to LVAD.
It came from the colonic surgery, from
the
Onalinquist was the pioneer of that.
So the pain management, the regional block seems to help with the respiratory mechanics and early extubation. I think this is what I heard from transplant pulmonologists. That's what they do at the time of the transplant to facilitate early extubation. Again, some surgeons would want to do that and some surgeons don't. It depends on the expertise of your team. Our lung team does that, and we're trying to adopt that from their expertise. So because of the pain, they're not taking adequate, that's going to prolong the length of time they're going to be on the breathing tube. So that theoretically it helps, and I have clearly seen it help in lung transplant patients. We would want it. Currently, we're not doing it. We would want to. We would want to go in that direction. So a new. So once they start feeling better, they go to old habits. And they will get nutritional rehabilitation post-operatively when your nutritionist is giving the food. Afterwards, it depends on, it's between God, you, and them. It is not covered with insurance, to be very honest, and it's a self-motivated thing. And most of the transplant program we have, even at the law, no reimbursement, we take nutritionists just because you have to see beyond the temporary gain, because the money you pay for a nutritionist may not be reimbursable, but your length of stay reduction can profit in a different way for the program. So you assume that cost upfront, and we do support nutritional rehabilitation for that reason. That's a decision that the team has to make. What is the upfront investment that you're going to have? What are the gains you have as an institute versus kind of seeing immediate money versus a long-term goal and vision for the program?
Just one last question. How long and how many people counsel the patient before they are given the option?
So, it's a village that goes to the patient and talks to a degree. Sometimes they each interpret what you say differently, and it is good and bad. But what I say upfront to my patients is, you're going to meet a lot of people. You're going to hear different things in different words, because each one of us are trained in different places, different countries, whatever. The choice of words could be different, but this is the whole essence of it. Please, if you have any confusion, talk to us. Basically, heart failure cardiology assumes the primary responsibility for this patient. So any confusion or questions, clarity, conflict of data, we will clarify that, and we give that reassurance to them up front. If you have any conflicting messages, talk to us. We are the responsible party. Except intra-op and post-operative, whatever the defined time, we are the point of contact for these patients. At least in our program. Okay, thank you very much for the opportunity, and I'm glad that I'm able to meet with all of you. Hopefully this is somewhat useful.
Thank you, Dr. Mridula. That was a wonderful session. That sums up, and I would like to call upon Dr. Krishna Prasad sir and Dr. Mata Prasad, send ahead, to give a memento, to present Dr. Mridula with a memento. I would invite Dr. Krishna Prasad sir to give a vote of thanks.
I know it's been a grueling session of a lot of information, and we can see the interest trickling down as we go. But that's what it is. That's the challenge we face as well. But I would like to thank each and everyone who has come. Thanks, Dr. Avinash Dal sir, and Dr. Ram Subramaniam sir, Dr. Amresh sir, for coming and moderating this session. And it's useful to have seniors participate and encourage. And I also thank all the moderators, Dr. Kumar Narayan sir and Ghansham, and so I think with this we'll conclude this session. And most important of all, I would like to thank Abbott for sponsoring this program. I know Zaki for the last 12 years. He was with Edwards for a very long time. Now he's shifted to Abbott, but he never gives up. He's a guy who picks up something that is at a very low volume, and then he keeps on egging at it so that it picks up. When he joined Edwards, that was a very costly valve, and just before he left, I ended up using it most frequently. So I hope the LVAD program also takes up, Zaki. So thanks once again, and we can have personal discussions over lunch. Thank you all.